Good morning, my lady. My lady Hazel Gray is the lady at the witness box. Could I ask for her to be sworn, please?
I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
That's great. Thank you so much for your contribution to the Impact film. It's extraordinarily moving, and I appreciate how difficult that must have been and how difficult it's going to be this morning. So thank you very much for what you're doing.
Thank you.
Thank you. Could you please give the inquiry your full name?
I'm Hazel Amanda Gray.
Thank you. Mrs. Gray, have you got a copy of the witness statement there with you?
I do.
It's a 26-page statement. Could I ask you to turn to the last page, please? It's a statement dated the 9th of April of this year. And can I ask you to confirm that the contents of that statement are true to the best of your knowledge and belief?
They are indeed.
Thank you. Now, my lady's already identified that you have already helpfully assisted Module 7 with the story you told us through the video about the death of your parents, Violet and George Little. We're going to start with that in a moment. But before doing so, can we just identify that the statement you have provided is a statement that gives the thematic issues in respect of TTI that are of significance to the group that you're a member of, the Northern Ireland COVID Bereaved Families for Justice?
That is correct.
And everyone will already be aware, but for the purposes of this module, it's a group that's been in place and started in December of 2021.
That's correct.
Now, could I ask you then to start with just expanding on what we already know from the impact videos that we watched yesterday about the thematic issues of concern relating to the care or what happened to your parents and their deaths, George and Violet Little, and perhaps to do so, it's clear from the impact video yesterday that they died a month apart. But can I ask you then just to explain what the thematic issues are that are of concern to you linked to their deaths, please?
Well, they died actually a month and a day apart, and the issues were, I presume, that a lot of people in the community presumed things were actually being done by our health trusts and by the government to prevent the spread of this virus. And only when it came to my own doorstep did I realise just that what I presumed was not actually happening at all, and that people who are working with vulnerable people and people who were going to get particularly ill if they got the virus, the carers coming to my mother were actually not being tested, nor were other healthcare workers. And to me, it seemed to be a total lack of common sense that this was 9 months into the pandemic, not 2 weeks or 2 months. This was 9 months later, and these people were actually spreading a virus.
Thank you.
And nothing was being done to counteract that.
You tell us in the witness statement a little about the health conditions that your mother in particular had and how your father was concerned to protect her from the virus. And perhaps if we just identify the visits from the carers, it's right, isn't it, that your parents lived in quite a rural area in County Fermanagh?
That's a very rural area. The nearest neighbours are about a mile away, totally surrounded by beautiful countryside. And, they lived in a beautiful house. And my father, whenever the pandemic started, before the pandemic started, he would have been my mum's main carer 24 hours a day. But then there was a comprehensive care package that was in place where carers would have come in 4 times a day to hoist my mum in and out of her wheelchair and in and out of bed, completed personal care. My mum was as sharp as a pin mentally, but physically, because of previous complications of her health over the years, she was confined to a wheelchair for over 18 years. So we relied very, very heavily, me being an only child as well. it was more than my father and I could have managed to look after herself. So we did need those carers to come in 4 times a day. It didn't matter what day of the week it was every day of the year.
And you detail within the witness statement that because of how careful the family were being about visits and who was seeing your parents, that you are confident that the COVID came in with the carers. Is that correct?
That's correct, yes. I would have brought them their food, and my father didn't generally go out anymore whenever the pandemic came around. So they were isolated even then, sort of unless the carers or myself came or my daughters. But whenever my dad took the infection in his foot, that he ended up in the GP's, and that's when the test took place after the GP's recommendation. That came back positive the next day, and I immediately went and had a test, and I was negative. So I knew that it wasn't me that had passed the virus to them. And then my mum, obviously, we got her a postal test because of her, vulnerability in January. I didn't want to bring her out into the cold, wet, damp sort of atmosphere. And then hers came back positive as well. And then after hers came back positive, mine was positive as well. So I'm fairly confident that I didn't bring the virus to them, and nobody else would have been in the house other than the carers.
Now, you tell us in the witness statement, and in fact, I think it's something that you tell Robin Swan, who we have evidence from, that I think on identifying that your father had tested positive for COVID, you in fact spoke to the carers and asked them when they'd last been tested. And I think it was their response that really concerned and alarmed you. Could you just clarify what they told you about that when you spoke to them?
Well, when my father's test came back positive, my main concern was the carers were going to come within a few hours, and that I needed to be sure that they were aware that they would need to take extra precautions, as I would have thought they would need to do. And when I found the domiciliary care manager, this was a Saturday morning, so it was particularly hard to actually try and get somebody in, the healthcare system. So I did manage to get in touch with the domiciliary care manager, and I asked him that question: when was the last time the carers would have been tested? More thinking of them rather than, that they had spread it. And his answer was, it wasn't the hospital trust's policy to actually test carers who were going into the homes of vulnerable people.
Okay.
And that was the shocking realisation of that this was what was happening in the country, that carers were going into the homes of people who were not tested.
Now, I'm not going to display it on the screen, but what you've just described as being totally shocked, we see in the text message that you sent to Mr. Swan, I think who's someone you know.
I've known Robin Swan for a number of years through a youth organisation many years ago.
Okay. And I'm just going to read aspects of the text you sent on the 7th of December. So this is after your father's tested positive, is in the hospital and shortly before he died. You say this: "I'm sorry to contact you direct, Robin, and I'm sure you're busy, but I've made a discovery which has totally and utterly shocked me and mine. Unfortunately, my dad has tested COVID positive and is now in hospital. My mum is wheelchair bound and has 2 carers coming in 4 times a day. On getting my dad's result on Saturday morning, I asked my mum's carers when they were last tested, and they said they're never tested. I rang their manager and I've been informed it's not policy for carers in the community to be tested at all on a regular basis. I feel this has been the most likely cause of the transmission, as my dad rarely leaves the house, and I'm so confused as to how those looking after the most vulnerable are not being routinely screened. Again, I'm sorry to have to bring you this, but I thought best to go direct to you and see what the thoughts were in having this policy." And you've also provided the fact that almost immediately Mr. Swan responded and said he'd look into the matter.
That's right.
And perhaps then if we sort of move forward then equally, it's right, isn't it, that you went to school with Arlene Foster, and similarly when your father died, the terms of that message were also shared with her about a concern in the community about the lack of testing of the carers.
That's correct, yes.
Thank you. Now, we touched upon your father, but I think it's right also that you identified that your father died first and then a month later your mother passed away. And is there anything else in respect to the thematic issues linked to your mother's death and test, trace and isolate that you wanted to bring to the attention of her ladyship?
Just the fact that when my mother was in hospital, I kept getting messages from the hospital to say that my mum had tested positive. And when I would have queried the people from the Department of Health who were making the phone calls, they didn't know that my mother was actually in hospital, and they were using me as her contact, presuming that she was in the community. So there's some sort of a haphazard system was going on that the people in the places that should have known didn't know where my mum actually was. But the hospital kept testing my mother, which didn't quite mean anything to me. Why did they keep testing her? Other than that they were keeping her in isolation in hospital. The hospital where she was in actually had single beds, rooms, so there was no wards as such. Everybody in the new modern hospital had a single room. So my mum was really isolated. When we're talking of isolation, being in a room by yourself most of the day must have been the most horrendous experience, and not having anybody coming to visit. I mean, I can't begin to imagine what it must have been like for my mother, knowing that my father had passed away and nobody was there with her to comfort her. Okay. I mean, they did say on the day of her funeral, the 20th of, or the day of my father's funeral, the 20th of December, she actually watched the clock. And the doctor afterwards, whenever they asked me to come in, because she had basically slipped into unconscious state, said that she had watched the clock.
Okay. Now,
and she was very aware of the time, obviously.
Yeah. Now, we'll come on to one of the concerns you have in particular around potential recommendation around a situation where people have got tested positive but are dying, and what you would like to be considered for future recommendations. I'm not going to go into the detail, but you also speak very movingly in your statement about the impact yourself having to isolate, having tested positive at a time when both parents were in hospital, and the significant impact that had upon you, isolating in their remote family home and being alone, and the profound impact that had upon you.
So to this day, I find it extremely hard to even go into that house now. Okay. I tend to need somebody with me. I can't spend any length of time in the house. People say to me, why do I not go and live in the house? And I go, there's no way I could ever possibly, after experiencing those 10 days on my own, and I mean on my own, I had to experience my father's death on my own, and had to experience everything in between, trying to make contact with the hospital, trying to make funeral arrangements. Basically, you do everything on your own. I would never have risked passing this virus on to anybody else.
Thank you. Now, you've already identified that your parents' deaths were in December 2020 and January 2021, and your concerns that we're now 9 months after the pandemic and there's still these issues that you experience relating to testing that really concern you.
That's right, yes.
But can we move now to the thematic issues, please? And in doing so, we appreciate that a large number of those from Northern Ireland COVID bereaved Families for Justice have contributed to your statement. But in particular, we're grateful for the contributions provided as to their experience of these thematic issues from Caroline Lynn, Martina Ferguson, Marion Reynolds, Katrina Miles, Catherine and Claire Regan, and Tom Black. But can I summarise with you now, before we move to recommendations, just some of the thematic issues that have been identified in this witness statement. The statement details the concerns of the group about decisions at the outset of the pandemic and the failure to immediately prioritise testing in Northern Ireland. I think it's described as the lost month of February in 2020. Is there anything else you'd like to say about that issue on behalf of the group?
So just that there seemed to be a haphazard system in place. I say we had a system, and if it had to be continued, who's to say that it wouldn't have made differences? The people in the know who were making decisions seemed to just follow what England were doing. So that seemed to be just the process of we will follow sort of the leader. So when we had a system, maybe we should have been actually using the system rather than just let's not do this anymore.
And I think that's one of the thematic issues identified in the statement about the suspension of community testing and contact tracing in Northern Ireland in early March 2020, when the group believed there was available capacity still within Northern Ireland.
That's right.
Thank you. Now, you've already told us about the concern around the testing of the care workers, but I think it's right also that you'd identified an issue linked to the testing of the paramedics that attended on your parents. Is there anything you want to say about that, please?
Again, something which to me is very common sense would be that somebody who is coming to actually see to somebody who isn't well should be properly equipped and not just wear a basic plastic apron and a mask and a pair of gloves. Paramedics were coming to my father and my mother in their uniforms, just with basic PPE. And when I asked them, did they get tested? They said no. Who would do their jobs if they were going to be tested and come back positive? So it was this attitude of, if we don't get tested, we won't know whether we're positive or not. So that was obviously, again, a big issue, that this virus was being spread by people who were doing their jobs and caring for people who were already sick. So the process to me just did not make sense. Prevention is always better than cure.
Thank you. Now, the statement also details, and perhaps if you allow me to headline these before we move to conclusions, concerns about failures in implementing a system of backward contact tracing or to appreciate the benefits of tracing as a theme.
Yes.
Discharge from hospital to care homes following a positive test or no test.
Yes.
The absence of a robust system to test, trace and isolate the virus, and the detrimental impact of isolation of vulnerable groups and individuals.
Yes.
Inadequate measures to protect those benefiting from care, testing within care homes and healthcare facilities, including at the point of transfer from one to the other.
Yes.
Not effectively using measures such as testing to lessen restrictions and isolation.
Yes.
The absence of routine testing of healthcare workers, very much an issue linked to your parents' deaths.
Very much so. I'd say paramedics, carers, nurses, anybody in that profession, I believe there should have been more robust measures in place. Yeah. Any measures would have been better than no measures at all to actually test.
And another theme that's identified in the statement is inadequate financial support provided to those required to isolate and the financial incentive to avoid self-isolating by workers.
Yes, that was a fear that I thought, is it because people are afraid of losing, money that they are just bypassing, will not get tested?
Thank you. Now, the statement with the full 26 pages of thematic concerns of the group will be published. Is there anything else about those thematic issues before I move to the conclusion of the statement that you'd wish to draw to the attention of Her Ladyship?
No, I say the full statement will include all the concerns, and I say it has just been shocking to find out what way the country was being run. And you say, so many people like myself had a presumption that measures were being taken when they weren't. And I say it's not rocket science, it's common sense, most of it.
Now, before I go to that conclusion, one of the things that you detail within the statement is you say this about the circumstances of you having COVID and wanting to be with your parents. You say, this has left me with a strong feeling that it must be a human right to have someone with you when you pass away where this is possible. You say that you believe this view is consistent with the views of many of the group, and you ask that the inquiry consider this when making recommendations for the use of isolation in any future pandemic.
Yes, I say if it had been an animal, a vet would encourage the animal owner to be there with them until the very end.
Okay.
I twice didn't get that opportunity, and so many people have had that similar experience. The trauma of not being there for your parents' last breaths will stay with me forever. And I know there's so many people that is the ultimate just piece of hurtful experience that they had. My parents disappeared.
Yeah.
I never seen them again.
Now, before I move to the conclusion, and it's perhaps just more a general issue, the inquiry and that her ladyship has already heard much about the impact of no funerals, but perhaps just to identify, even though there was no funeral for your father, he was a significant member in the community, a band member all his life, but his band essentially lined the street as he went past in the hearse as a mark of tribute, but that equally is something that you just wanted to be noted around the further impact of the loss of your father.
Yes, I say he deserved a send-off. He didn't get a send-off. I mean, people tried their best. They lined the roads, they lined the streets.
Thank you.
It was as much as anybody could do to do that for him.
So then, let me then just deal with the conclusions, please. The statement of the group says this: we would ask that the inquiry ensure that the above issues are considered and addressed in this module, and that recommendations are made to prevent the failings which this statement identifies and other such failings from being repeated in the future. One overarching issue raised is the apparent lack of humanity and common sense, which is apparent from what is described above. I would hope that one important lesson learned is that this should be central to any response in the future.
Most certainly.
And I think you finally wish to leave with your views as to what the bottom line of all of this is. Could you just perhaps deal with your bottom line, please?
My parents, their lives were cut short prematurely, and their experience was horrendous for me, for them, for the whole country. All those who were lost, their lives must not have meant nothing. They cannot have died in vain. We must have changes in this country, and we must have positive changes that people never have to experience this type of trauma over a virus again. I say prevention is better than cure, and measures must be put in place now. And I plead with all the people that can make this difference. We must be prepared, because this could happen again at any time.
Mrs. Gray, thank you.
Thank you.
Mrs. Gray, thank you very much indeed. You've done your very best to make sure they didn't die in vain, so thank you so much for what you've done. You're obviously a devoted daughter. Have you got people to support you in your grief?
Yeah, I thankfully
Apart from
have.
members of the
I have,
families?
yeah, my daughter with me today, and my other daughter and my partner hopefully are watching at home.
Well, I'm sure they'll do their very best to get you through it. It's going to take a long time.
Yeah, I just want to thank everybody in the Northern Ireland COVID bereaved Families for Justice as well, and our legal team.
Thank you very much indeed.
Thank you.
Thank you. Thank you, Mrs. Gray. My lady, the next witness, Nicola Boyle, on behalf of Scottish COVID bereaved, is appearing over the link. Could I then please call Nicola Boyle? Sorry, thank you. Can you manage? It's okay. Well done.
Ms Boyle, I hope we haven't kept you waiting. Can you hear me?
Yes, I can.
We were just setting up the screens so that Ms Cartwright could see and hear you as well.
I'm afraid I can't see the witness at the moment. I'm going to twist
Oh,
rather
okay.
than delay. Could I ask, please, for the witness to be sworn?
Yes, certainly. Can you see and hear me?
Yes.
Okay. And I understand that you wish to affirm.
Yes, please.
Okay, if you'd like to repeat after me. I do solemnly, sincerely,
I do solemnly, sincerely,
and truly declare and affirm
and truly declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Is there anything we can do to increase the volume?
I don't, if that could take place.
Right, we're going to make efforts to. At the moment, you're fairly. So I don't know if it's because the volume's turned down too much or you're very softly spoken. So we'll do what we can to improve it. But in the meantime, Ms Cartwright will
Thank
carry
you. Could I ask you, please, to give your full name to the inquiry?
It's Nicola Rachel Boyle.
Thank you. And Mrs. Boyle, can I check? Can you see and hear me?
Yes.
Thank you. Can we then please start with identifying the statement that you provided to the inquiry? It's a statement dated the 10th of April of 2025. It's 26 pages. And are the contents of that statement true to the best of your knowledge and belief?
Yes, they are.
Thank you. Mrs. Boyle, can we firstly thank you because your statement is provided on behalf of Scottish COVID bereaved. And it's right, isn't it, that you detail within this statement that the common goal of the group of the bereaved members of Scottish COVID bereaved is that you do not want your loved one's deaths to have been in vain. You want lessons to be learned to prevent others having to experience what you have been through, and that you believe that by sharing your experiences, both good and bad, that you will assist this inquiry in establishing what really happened and to reach appropriate conclusions, recommendations and lessons to be learned.
Yes, that's correct.
Now, Mrs. Boyle, we're going to look together at some of the thematic issues which are eloquently set out over the 26 pages. But before doing so, do you wish to identify some of the thematic issues of concerns to you and your family arising out of the death of your mother-in-law, Margaret Boyle?
Yes, I do. Thank you very much.
And just pause for a moment. My lady, if you wanted to follow that passage of the statement, it starts at paragraph 86.
Thank you.
Sorry to interrupt you, Mrs. Boyle. Please now identify the issues that arose in Margaret Boyle's case and her death that are a concern to you and your family.
Thank you. We lost my mother-in-law on the 20th of October 2020. She lived alone. She'd some underlying health conditions, but still lived a very independent life. She was very much a hands-on with her children, her grandchildren, very family-orientated. It really was the backbone of her family. When the pandemic began, she shielded for a number of months. That left her very alone and isolated. She lived alone and she wasn't able to see family as she normally would, mostly every day. So that really affected her quite a bit. There was a pause in shielding, if I recall correctly. I think it was perhaps around about August of that year. There was a certain relaxations of the shielding restrictions. At that point, I think she was just felt so affected mentally by the months and months of being alone that she did decide to go out into the community as far as the restrictions would allow. So when she contracted COVID, it was community transmission. We don't know exactly where. It became apparent that she was very unwell with COVID. We suspected that she had COVID. We more or less knew she did, but it was trying to get her access to a test at that point. So my husband and I had COVID a couple of weeks, maybe about a week before she did. She was too unwell to leave the house to order a test, so she did have some technology in the home, but she wasn't particularly digitally literate. She was able to use it, but needed generally to be coached by a family member. And in any case, at that point, she was probably too unwell to be able to negotiate ordering a test online. So I did it for her. I ordered the test online, and we lived in a different local authority area from her. And it took, I guess, about 48 hours to arrive. By that point, her health had deteriorated quite significantly. She was too unwell to even go from upstairs in her bedroom down to the front door to collect the test, which had been posted through the letterbox. An ambulance was called for her, and the ambulance crew attended and administered the test for her. However, it wasn't registered. The ambulance crew didn't register it, and she wasn't able to at that point. She wasn't admitted to hospital. The ambulance crew took the test away and posted it through a priority post box. However, it wasn't registered, so it just disappeared. We never ever got those test results. Days and days later, my husband then, because we just had COVID, he actually drove over and had to take her to a mobile testing centre, which was probably about 13 miles away, was the closest appointment that she could get. So my husband took her and then returned her to home. She was then subsequently became even more unwell and was admitted to hospital, still with no test results at all. And finally, the hospital tested her on admission and confirmed what we'd known all along, that she'd had COVID. And by that point, she was really gravely ill. And probably, I think it was less than 40 hours after admission to hospital, she died alone, in a room alone. There was no one with her when she died. We weren't allowed to visit her. And we think the hospital don't really know what time she died at. We think she'd maybe been dead for about half an hour or so before she was discovered.
Thank you. Now you across that, the issues of various different tests, either test results not arriving or then the issue about not getting results. You've mentioned your husband taking your mother-in-law to that test centre. You, I think, say in your statement that it wasn't local, but the only location where a test was available, and that further raised a concern about poor accessibility for the vulnerable and marginalised, who wouldn't have had ease of access to transport like your mother-in-law had.
No, I mean, she had a car, but she wasn't well enough to drive at all. So that's correct.
Okay. Mrs. Boyle, is there anything else you want to say then about the thematic issues linked to Margaret Boyle's death on the 20th of October 2020? But if not, we can move to the thematic issues.
Yeah, I think just in summary, she was elderly, vulnerable, and we feel that she was just, people like her were just forgotten about, really, there was little or no support, and she was so alone during that time and subsequently died alone.
Thank you. Now, Mrs. Boyle, the statement that deals with all of the thematic issues will be published, but can we just look at a number of those that are of most concern to Scottish COVID bereaved? One of the issues that's identified in the statement is the link between nosocomial and care home deaths and issues with the United Kingdom's ability to successfully test, trace and isolate. Is that correct?
Yes.
The statement also details concerns relating to testing criteria, symptoms and delays in expanding wider recognition of symptoms of COVID-19. And you say in the statement that this was due to the lead on this being taken by the UK government and UK HSE. And the group has a concern of the impact this had on delayed diagnosis and treatment, notwithstanding good practice guidance, particularly regarding the elderly, and the Zoe study list of symptoms.
Yes.
And can I briefly then on that issue, we're grateful for the Scottish COVID bereaved for bringing to the inquiry's attention the British Geriatric Society guidance, and very briefly, sorry, it won't be displayed on the screen, but my lady, for your note, and it will be published, it's INQ 00587314. And I know, Mrs. Boyle, you've had a chance to consider that document, and page 3 of that guidance from the 25th of March 2020 by the British Geriatric Society identified that in respect of COVID-19 in care homes, residents may commonly present with non-respiratory tract symptoms such as new onset, worsening confusion or diarrhoea. And again, I think that's an issue in particular the group wished to draw to the attention around essentially the classical symptoms not being there for the elderly and it being known in March of 2020.
Yes, that's
Thank
correct.
you. I think it's right, isn't it, that a further thematic issue is the lack of testing in care homes and hospitals, leading to spread of infection.
Yes, absolutely. As you'll see from the statement, our members have plenty of examples, unfortunately, around that very.
And I think perhaps on the same theme, the statement details inadequate and delayed testing within healthcare and care settings, but also the failure to test upon transfers between hospitals and care homes.
Yes, that's correct.
The statement also draws out variations in isolation policy and strategies across Scotland and the United Kingdom, and the inconsistency in how isolation policies were implemented and adhered to.
Yes, absolutely, yes.
The statement also identifies the issue of accessibility of mobile testing centres in Scotland for those living in rural areas and the borders.
Yes, that's correct, and not even just rural areas and the borders, even in the bigger cities where testing was supposed to be more accessible as well. It wasn't.
You've also identified in the statement poor communication and guidance in respect of TTI and the impact on vulnerable groups and marginalised in society. And I think you treat your mother-in-law as one of those also. The statement also identifies an issue of concern regarding the Scottish local authority boundary system that was designed with a view to ease of policing rather than risk-based, and that's drawn out in the statement. Is that correct?
That's correct. And the example actually of my husband driving to my mother-in-law's house to take her for a test, strictly speaking, he was breaking the rules because he was going into another local authority area.
Thank you. And I think you've also identified in the statement the confusing different approaches to certainly across Scotland and the United and England as to guidance, and the confusion that resulted in respect of different approach in different areas. Is that correct?
Yes, yes.
Okay. I think there's also a concern of the group around when the lateral flow test was stopped and the free tests were withdrawn, and the impact on those of low income.
Yes.
And you've also identified, I think, lack of provision of financial and practical support for those required to isolate.
Yes, yes. Our members, well, in the statement, we draw that out as well. People were, we understand, just scared of losing money or being financially ruined if they didn't turn up for work. And that would have affected their adherence to the rules.
And I think the statement also identifies the overwhelming of contact tracing capacity in the early stages of the pandemic.
Yes. Tests were too slow, so what was the point apart from the inconsistencies within the contact tracing? If the testing's too slow, then that calls into question the efficiency of the whole model.
Thank you. Can we then please, unless there's any other of the thematic issues, and I appreciate there are many, many more detailed in the statement, is there anything else you want to draw out before we just briefly deal with recommendations set out in the statement?
No, thank you.
No. The statement ends from paragraph 111 through to 127 with giving the views of Scottish COVID bereaved in respect of lessons learning and recommendations. And perhaps if we just look at a number of those together, you've identified by the group that in respect of testing, that testing protocols and guidance in the early part of the pandemic were focused on those individuals arriving in or returning to the United Kingdom from other countries. And you have identified that no cognizance was taken of the risks of asymptomatic transmission, although this was understood from at least January 2022.
That's correct, yes.
Again, just identifying one of the recommendations in respect of tracing, you say that tracing of staff and patients in hospitals and healthcare settings was plagued by wholly insufficient testing capacity. And your members believe that in the early stages of the pandemic, the delay in getting the test results back, which could be as much as 5 days, significantly contributed to the rapid, extensive and catastrophic transmission of COVID in hospital and healthcare settings.
Yes.
And then in respect of isolation, you've identified that the members' experience demonstrate that within different care homes and hospitals, sometimes even in the same ward, there was inconsistency in how isolation policies and guidelines were implemented and adhered to.
Yes.
You also offer observations to her ladyship that she can consider with care around scaling up prioritisation and discharge of patients from hospitals to care homes. But you say that this, at paragraph 124, planning for a future pandemic should include robust systems for step-down care facilities to relieve the pressure on acute hospitals, like the use of Nightingale hospitals with provision for staffing from, for example, a pool of recently retired staff deployed due to pause in routine work, those in the Army or Navy Reserves, final year medical and nursing students under supervision.
Yes.
And you say this, that if such testing is available in a future pandemic, we believe that no patient with a positive test or with known exposure to the pathogen and with a test result which could be a false positive, for example, a situation where an individual may test negative on day 2, but positive on day 3, should be discharged into a nursing or care home unless that home has facilities for barrier nursing and full PPE. Thank you. And then finally, in conclusion, Mrs. Boyle, you say this: it's clear to the Scottish COVID bereaved that testing capacity in the United Kingdom and Scotland was inadequate at the start of the pandemic. Serious improvements must be made going forward to ensure that the UK has the ability to scale up test and trace systems quickly when required. This is an issue of great importance to our members, as ultimately this is key to preventing the spread of virus.
Yes.
And then finally, test, trace and isolate is the key to protecting the most vulnerable in our society in future pandemics. It is also key to allowing relatives to be able to visit vulnerable loved ones in care settings and hospital settings and to be with their loved ones at the end of life. Going forward, there requires to be a test, trace and isolate system that is adequate, efficient, well-resourced and can be quickly put into operation when required for future pandemics.
Yes, that's correct.
Mrs. Boyle, is there anything further you wish to say before concluding your evidence?
No, I know that her ladyship has the statement. I don't want to draw out any more individual instances because each of our members' experience is equally as important. So I just leave my statement with you.
Thank you. Thank you, Mrs. Boyle. My lady.
Thank you very much indeed, Mrs. Boyle. I was just looking through your statement. You and your group raised your concerns relatively early on, didn't you, about a year into the pandemic with the likes of Ms Sturgeon and Mr Swinney and Mr Youssef. Did anything change as a result of your raising the issues with the leaders of the Scottish Government?
Now, this is slightly difficult for me to answer, I'm afraid, my lady, because I was not a member of the group until June 2023.
All right.
I wasn't actually involved in that process, so I regret that I can't assist on that issue specifically. I wouldn't want to mislead the inquiry.
No, totally understood. Thank you very much indeed. Well, thank you for all that you've done to help the inquiry and all that you obviously did to try and help your mother-in-law as well. Thank you very much.
Thank you.
Ms Mitchell, have you had a chance to talk to Mrs Boyle? And you're okay to carry on? Thank you very much, Ms Boyle. I'll ask them to cut the link now.
Thank you. My lady, the next witness is in person. It's Professor Martin McKee, please. Sorry, could the witness please be sworn? Thank you.
I'd like to take the Bible. I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but
and
the
nothing
truth.
but the truth. Thank you.
Thank you. Could you please give the inquiry your full name?
Clifford Martin McKee.
Professor McKee, do you have a copy of your witness statement in front
I
of you?
do.
It's 33 pages. It's dated the 3rd of February of 2025, where we see your signature on that last page. And can I ask you to confirm, is the content of that statement true to the best of your knowledge and belief?
It is.
Thank you. Now, Professor McKee, you set out extensively within the witness statement your background, qualifications, experience and expertise, but can we together just identify those matters? It's right, isn't it, that you are a Professor of European Public Health and Medical Director at the London School of Hygiene and Tropical Medicine?
I was the medical director up until 2023, but I'm no longer.
Thank you. And could you just give us some idea as to how long you've been a Professor of European Public Health?
Oh, since about 1997.
Thank you. You are one of the research directors of the European Observatory on Health Systems and Policies.
That's right.
And that was a partnership posting by the WHO.
That's right. It's a partnership of governments, international agencies and universities.
Thank you. You were and are a member of Independent Sage.
Yes, I am.
And you are a member of the EU expert panel on effective ways of investing in health.
Yes, again, I was a member for its 3 terms, but it then ceased to exist.
And can we just have some idea then when it ceased to exist, please?
About 2 years into the pandemic.
Thank you.
And then other arrangements were put in place.
Thank you. Can you then please just help us with your role as a research director of the European Observatory and the joint responsibility for the COVID-19 Health System Response Monitor that was used to collate information on national responses to COVID-19, again, run in partnership with the WHO and the European Commission. So it might be helpful for her ladyship to understand a little bit about that role, please.
Of course. So the observatory, 4 of us established it in 1997, initially with a number of European governments and the World Health Organization. We have now expanded to, I think, 11 governments, the European Commission, the World Health Organization, London School of Hygiene and Tropical Medicine, London School of Economics, Technical University Berlin, the Health Foundation in the UK. And we provide the material for the rotating EU presidency, the health reports. We provide a series of profiles of health systems in countries across Europe and other high-income countries, and we do a whole series of studies on different topics. We've done quite a lot on resilience, for example, in the light of the pandemic. I'm currently leading our work on artificial intelligence and health, but we cover a very broad range of issues. And my responsibility is to liaise with our partners who are in the various governments, and particularly with the World Health Organization and the European Commission, to make sure that the work that we're doing is meeting their needs and expectations.
So I don't have a stenographer on strike. If you could try and slow down, Professor
Sorry.
McKee, I'd be really grateful. Thank you.
Sorry, I beg your pardon, my lady.
Thank you. Now, you are also a health advisor to the WHO Regional Director for Europe.
That's right.
You're a member of the Pan-European Commission on Health and Sustainable Development in the light of the pandemic.
That was a report that was commissioned by the WHO Regional Director. It was chaired by Mario Monti, the former Italian Prime Minister and European Commissioner. I was the rapporteur, so I drafted the report and I wrote the evidence review. But it was other commissioners were mainly retired senior politicians, people from central banks, that sort of thing. Lord O'Neill, for example, from the UK was a member.
Thank you. And I think just to for my purpose, before I ask you to clarify anything else from your expertise and experience, you're also a former president of the British Medical Association, having that term between 2022 and 2023.
I am, yes, or I was.
Professor McKee, we've summarised there decades of knowledge and experience. Is there anything else that I've not drawn out with you at the moment that's relevant to your knowledge and expertise before we get into the detail of your evidence?
No, I think that covers everything. But if you will permit me just to express my sympathy for all of those who lost family and friends during the pandemic, and also my thanks to all of those who contributed in so many ways to the response.
Thank you. Now, we're going to look at a number of topics together during the course of just over an hour or so with myself. But can we start with dealing with your role during the pandemic and contributions to Independent Sage? My lady has already heard much about Independent Sage, but can you sort of, first of all, just briefly deal with Independent Sage and its role during the pandemic, please?
We were a group of scientists from a range of disciplines who felt that there was a gap, and it was one that we could potentially fill. It came from the way in which we looked at the relationship between evidence and policy, and of course that's directly relevant to my work in the European Observatory. I think there was a sense that questions were being asked of the scientific community in the UK without them necessarily knowing why the questions were being asked. And we've had many examples. My colleague at the London School, Sir John Edmonds, has made the point that had they had a more nuanced understanding of the way in which care workers in social and long-term care homes might have multiple jobs in multiple homes, they would have developed the models differently. And he has given evidence to say that they were not aware of that because no one from social care was in the modelling group in SPI-M. So we felt that there is, first of all, an important value to bring together a wide range of disciplines. And again, this stems from my previous research, I should have said. In public health science, one of the main things we do is act as sort of glue between different disciplines and bodies of knowledge. My own personal research has included looking at the health effects of the collapse of the Soviet Union, of the global financial crisis. And there you're drawing work from laboratory science, from clinical medicine, all the way through the social sciences to political sciences to understand how it all comes together. So we felt that the advisory system, which had the virology group and NerveTag, the behavioural scientists in SPI-B, the modelling group in SPI-M, working almost in silos was not particularly helpful, and we might be able to add something to that. We also felt that it was important for, and there are differing views in this, and here we drew particularly on the lessons from the Phillips report into BSE and the scientific and its comments and scientific advice. I find it particularly helpful to have dialogues with the policymakers I'm advising because I can understand why they're asking the question, and in particular where there are misunderstandings, because we are dealing with complex issues like exponential growth, for example, asymptomatic transmission, and often one finds that things that one side take for granted, the other side may not be aware of. So that ability to listen and to pick up on the clues that there may be a lack of understanding, we felt that that was important. The other thing that we felt was important was to look at how we communicated evidence. Because again, from my work in the observatory in particular, we think a lot about cognitive biases. And there is a huge amount of evidence that two people with different views on the world, perhaps political views, given exactly the same evidence, this is including from clinical trials, where this has been done by randomizing them, they will interpret them in completely different ways. So that's why we felt it was important to find ways of synthesizing the information and communicating it, which we did in our weekly briefings and in our reports, trying to make it understandable, but very much listening to the concerns that people were having and understanding what information people wanted.
Thank you. And I think in respect of the reports published by Independent Stage, I think you identify there were some 130 or so during the pandemic, and that you contributed to almost all of them.
In some way or another.
Thank you. Now, we may look at the detail of a number of those during your evidence, because you particularly highlighted in your statement reports of significance to the systems of test, trace and isolate. It's right, isn't it, that Independent Stage provided a blueprint to achieve an excellent find, test, trace, isolate and support system that was published in October of 2020. Mm-hmm. And I think having made views known in May of 2020 about what the system required from the perspective of Independent Stage, that you produced a paper in respect of supported isolation in March of 2021 as to why supported isolation is crucial to prevent community transmission. Mm-hmm. And you provided reports on managed to supported quarantine in respect of key questions for the future in June of 2021. Mm-hmm. And perhaps just briefly, if I touch upon one of the reports that was provided in October 2021 from Independent Stage was a statement on COVID-19 testing at the Immensa Healthcare Clinic Dante Laboratories in Wolverhampton. And do you want to just briefly deal with the publication of that independent report about the Mensa lab? And can you just first of all identify what was the issue that was of concern to independent stage around testing at the Mensa lab?
So the issue with this laboratory, in fact, there were two contracts with this laboratory, the company operating the laboratory, which had a testing centre in Italy and then one in Wolverhampton in England, was that there were a growing number of reports that people who were testing positive on lateral flow tests were testing negative on the tests that were being done in the laboratory. And then, after some time, the work of the laboratory was ceased. But I think what concerned us was that this seemed to have been a problem that had been recognised by various people for some time. And in fact, it had been raised initially in a report in the Sun newspaper in January of that year. And then the Welsh authorities, the Welsh Government and Public Health Wales, had expressed concern. They were using it for surge testing, and they were getting aberrant results. And they raised it with the test and trace system in the UK test and trace system, and raised concerns. And nothing was done about this. But what particularly concerned us was that our philosophy was that we should be listening to ordinary people. And there was a Facebook group in Stroud in Gloucestershire who were recognising that there were quite a lot of people in their community who were testing positive on lateral flow tests but negative on the PCRs. And they were wondering why. And they raised the issue. And nothing was done about this. Now, of course, when we wrote our report, we could only account for what we could see that was in the public domain. Subsequently, UKHSA published a serious untoward incident report, which sheds much more light on it, which we didn't have in our report, and really highlights many of the concerns, in fact, all of the concerns that we had about this approach to testing. So, for example, it was claimed that the laboratory was accredited. It wasn't accredited. Many things were claimed. It was said that everything is under control. It wasn't under control. There were major failures of governance that were illustrated in the UKHSA report, which we did not have access to at the time. So I think that we put it out because it was illustrating this concern that we had that people who were raising issues were not being listened to. Public health community in Wales and this group in Gloucestershire. And that should have been a signal to do something about it. But letters, and again the UKHSA were able to look at the process and show that letters were not answered, not responded to. There were breakdowns of communication, many things that should have been done were not done.
Thank you. And I think that's additional information you've learned from having reviewed UKHSA's serious incident report in respect to the Mensa lab. And we'll take up that topic when we hear from Dr. Harries in due course. But can I ask you then, as a broad principle, without having yet even really looked at the detail of any of these independent SAGE reports, but can I ask, in your experience, to what extent did the government or the governments of the devolved nations meaningfully engage with advice from independent SAGE or follow its recommendations in respect of the test, trace, isolate system and the recommendations? So
the Scottish Government did engage, and a number of our members were based in Scotland. And in fact, we had very positive feedback from Ms Sturgeon on one occasion. And so there was that process, but it in a way took place not by virtue of our members being in the advisory groups. Of course, we did have some of our members were on SAGE in the UK, particularly in the behavioural and SPI-B. However, as I think you've heard elsewhere, there was a sense that sometimes the behavioural science bit was not heard as much as it might have been. And we were also heard in Northern Ireland, particularly by the Assembly, and several of us were invited to give evidence to the Assembly Health Committee. And we understand that it was listened to in Wales. But in terms of England, when we wrote our initial report, we were very determined not in any way to be unhelpful. we felt that our contribution was that we could answer questions that were not put to the scientific community, the scientific advisory group, but we shouldn't be contradicting them, the scientific advice, unless there was a very good reason. And I don't think we ever actually did. There might have been slight nuance, but we were saying very much the same things. So I did share, before publication, our first report with senior colleagues in the medical part of the Department of Health, and made one or two small edits. But after that, there was no real interest at all.
Okay, thank
Was
you.
it thought that you were second-guessing SAGE in England?
Well, I think that I think you have already asked Sir Patrick Vallance about this, and certainly there was a view there. And obviously, we were initially established by Sir David King, my lady, and who had been in his role before. We did not feel in any way that we were, and we took great care not to. Because that would have been very unhelpful, particularly in a climate of disinformation. The last thing that we wanted to do was undermine trust, and we really took quite a lot of care to do that. But I think, unfortunately, although the personal relationships were fine, there was that perception, but not from us, and when we really worked very hard to prevent that from happening.
Thank you.
Okay. Now, I've no doubt that the Government Office for Science would want it to be made absolutely clear that SAGE's position was to provide advice and advice to specific questions asked, but that they were not the decision makers.
Of course.
And similarly, that the context of SAGE advice was often in the context of a specific ask without then knowing what happened to it afterwards. But from your knowledge and experience of members that contributed to SAGE, is there anything else you'd wish to say about the need and role that independent SAGE were playing at this time?
I think if you do look at some of the statements that have been made, there's clearly a difference in view. In the light of this reviewed statements by Sir Chris Whitty, Sir Jonathan Van Tam and others who have differing views about the relationship between science and policy. And I think in one of Sir Chris's comments, he talks about this issue of to what extent, in fact, he says, if you will forgive me, he says that, in fact, the scientific advisory group should answer the questions, should spend about, I think he said, about 80% of its time on doing that, but it should have the opportunity to raise other things as well. Otherwise, it's only a branch of government. I don't think that view was shared by everybody. Other people felt that it should only answer the questions. So there are, my understanding from reading the witness statements that they gave to your inquiry, my lady, is that there were differing views on this, subtly differing views.
Thank you. Could we then please identify two different ways of describing the test, trace, isolate that you've detailed in your witness statement, and perhaps just give an explanation? It's a matter that's been touched upon by way of the terminology of the testing and tracing mattering. Can you explain why you've described the system of find, test, trace, isolate support rather than simply test, trace, isolate? What's the significance of a system of find, test, trace, isolate support?
So I think we see this system, whatever it is, as a system that has many different elements, all of which need to work together. And there is very little point in having a perfect testing system if you don't actually find the cases. You need, I think, the experience that we've seen in other countries, and particularly the very recent evidence that had been gained from the Ebola outbreak. Again, a lot of lessons that were learnt from that, that should have been learnt from that, weren't. What was happening in South Korea, for example, the importance of going out to find cases was a critical part. In a way, it's like opening up a shop and saying, well, it's available, it's there, it can be used, and nobody comes. So you do need to proactively go out and find cases. And then the support at the end, was that we knew that if you were telling people to isolate, they would need some support. And in this, I was able to draw on my work in the global financial crisis, because one of the issues that we recognized in our research was the concept of precarious existence, precarity. which was very prominent in the Francophone literature until about 2012 and not so much in the Anglophone literature. But it's the challenge of those people whose lives are characterized by uncertainty from one week to the next of whether they will have income, employment, food or shelter. And for them, the ability to comply or adhere to instructions is really very, very challenging. So we felt that it was important to look at their needs and to support them. And indeed, separately from Independence Age, we published a paper with my colleagues from Glasgow, Margaret Douglas and others, in the British Medical Journal, I think about April of 2020, in which we were absolutely clear about the need to interrupt the transmission of the virus, but also recognized that that would have many consequences for education, for employment, and particularly for the large number of people in the UK in the gig economy, in the informal economy, in multiple employment. And it was really important to understand their lived experiences and to put in place systems that would support them. Otherwise, you could, with the best will in the world, they may want to do that, but they simply can't.
Thank you. Can I ask you your views, having given a context to the wider system of find, test, trace, isolate support, of the importance of engagement of effective groups when devising schemes for financial support?
Absolutely, because again, I mean, this stems from work that many of us have done, but when you're trying to put in place, you have a sort of ideal model of an implementation of something that you want to put in place. But if you don't do the work to understand the lived reality of people, maybe I could give an example of another study. I mean, this may seem almost irrelevant, but it is actually not, where I do a lot of work in cardiovascular research worldwide. And a clinical trial we did of an innovation in Malaysia and in Colombia, where we spent a year working with the communities. The basic elements of the intervention were the same in both countries, but we spent a year working with the communities to understand in these rural areas the lived reality and to design our intervention to be consistent with that. We need to find out how people live their lives, what they do on a Tuesday morning, what they do on a Friday evening. What are their fears? What are their anxieties? So I think we felt that that was crucial. And of course, community leaders can play a role in that. I'm not naive. You can't start going out and doing extensive long-term research in the middle of a pandemic. But I think you need to be gathering all the information you can and not be doing it on a sort of preconceived template of where you go and do things. You should be, again, like my point about the Facebook group and the Imensa laboratory, when signals come in from somewhere, we should be making use of them. In a way, drawing on what the intelligence services now do, and with the concept of open source intelligence, the same sort of idea.
Thank you. I'm going to ask, please, to be displayed, please. It's paragraph 11 of your witness statement, which is INQ 475066. It's internal page 5, please. Now, just to orientate ourselves, we're on the 4th of May 2020, following a public briefing from Independence Age. And we can see detailed within this paragraph, it said as follows: can we take a whole systems approach to understanding, tracking and tracing? We are arguing for someone to map out all the functions that need to be in place, from accurate population registers to quality control of tests, and with a particular focus on the boots on the ground, which I would argue will have to be in local authority, public health and environmental health departments. Now, can I ask you, first of all, you referenced boots on the ground and local authority public health. Do you have any comment on the use of the public health structures in May of 2020 in respect of this system of test, trace and isolate?
I think that, my lady, your inquiry has already heard quite a lot of evidence that people in the public health community felt that they were left out of the system, that they were not they were not brought in, and yet when they were, as in Leicester or Sandwell, and you will be hearing later from Liverpool, then that actually made a material difference because they understood the local context. And again, later in my witness statement, I provide links to accounts of, in particular Leicester, where you had a challenge with multiple languages being used. And in fact, we've heard on the impact statements and so on of the challenges of not doing that. The approach that we were advocating here is one that we use in our research anyway. The need for looking at a problem. To give you some examples from my own work, why is it that people with type 1 diabetes in many countries in the world are dying unnecessarily? Insulin has been discovered since 1921. It should be easily available, but there are so many things that need to come together to get the insulin into the country through the airport, distributed across the country, to have the trained staff who can, and the pharmacists and so on. So when dealing with an issue like this, or our work on cancer screening, which was what I referred to at the bottom there, you need to have everything in place. And you need to not just look at one focus. It's not just about having lots of tests. We know, to take an example, with cervical screening as an example, Germany does vastly more cervical screening tests than Finland, and yet gets far worse outcomes because it's not organised and there isn't a systematic approach. In Finland, they have a systems approach and it works.
Thank you. And so can I ask you, with that paragraph identifying the need for a whole system approach, we know this is the beginning of May of 2020, and that by the 28th of May of 2020, each of the 4 nations had implemented their strategy under different titles for test, trace and isolate. Are you able to comment on whether each of the nations did implement whole systems approach in their TTI strategies?
I didn't really see evidence of that, to be perfectly honest. And that, of course, I was not in the room where it happened, so it may be that these things were discussed. And of course, there were many practical challenges, so I don't want to second guess what people do. But the nature of the dialogue that was reported in the number of tests being done and so on did not signify to me that these issues were being taken account of, and particularly when we listen to, from the impact statements, the reports of where do you go to get a test, how easy is it to get there, how fast can it be got back. These are all the things that a systems analysis would do, and which were done in countries like South Korea and Germany and so on.
Thank you. We'll look at those together a little later, your evidence, but before we take a break, could I ask you just to give us a bit more detail around a document I displayed yesterday as part of my opening, which is, in fact, you and your professional colleagues are the authors of the Win the Game. Please could we display INQ 587459, the snakes and ladders. And perhaps can I first of all ask what you were intending to demonstrate by using snakes and ladders, and how the need for test, trace and isolate how that process should work, please.
So I think what we were trying to convey was that we did need a systems approach, that it wasn't just about doing lots of tests, that you needed to have all of the elements in place. So it was a way of trying to represent a systems approach. But the other thing I would say was that this was really part of our view, that you need to try to explain these ideas in ways that are understandable. We know, for example, and your ladyship has already heard about the challenges that people face with concepts like exponential growth. There are international surveys of graphic literacy and the ability to understand graphs, which is unfortunately, sadly, much lower than we might want it to be. So therefore, when we are communicating science, we need to think of other ways of doing it. Now, others will judge whether this was successful or not, but we felt that it was a way to catch people's attention, to make the point that you needed to have all of these elements in place, and that there are, in a way, the snakes and the ladders are what we would talk, if I was giving a lecture on systems theory, I would say this is about the path dependency, the nonlinear relationships, and the feedback loops which characterize complex systems. But this is perhaps a better way of explaining it to people who aren't into the issues of complexity theory.
Thank you. My lady, is that a convenient place to take a break?
Perfect timing.
Thank you.
That's quite right. We take regular breaks, Professor. I hope you were warned. For the sake of everyone, particularly the stenographer, I shall return at 11:30.
Thank you.
That's quite right.
Thank you. Now, Professor McKee, I just want to deal with some aspects of chronology in this system and independent stages view. And to start this next portion of questioning, can we just look at your paragraph 14? It doesn't need to be displayed.
Paragraph 40.
14, you
14.
say on the 11th of September 2020, we, that's Independent Sage, published a report titled Testing for COVID-19, the Why, the Who and the How. In summary, we emphasise that controlling COVID-19, especially without widespread immunity, requires an integrated approach involving expanded testing, rapid contact tracing and effective isolation measures. The goal is to achieve minimal transmission rates, thereby avoiding damaging lockdowns. Testing is seen as a comprehensive pathway that begins with identifying individuals for testing and leads to actionable public health interventions. And it says, we criticise the UK testing system, NHS Test and Trace, for focusing on volume rather than effectiveness. And can you just expand on what the criticism is around volume rather than effectiveness?
Well, we obviously needed to have lots of tests, so volume was important, but it should not be an end in its own right. And again, I go back to my earlier point to use the example of cervical screening, where there are countries that do lots and lots of cervical smears but actually get very, very poor outcomes because they're not doing it as part of a comprehensive system, not necessarily screening the right people, the people at most risk, and then not having it as part of an integrated pathway so that if a woman gets a positive result, then she's followed up and gets appropriate treatment. So this was very much in keeping with the way in which, with our approach to research in health systems, in that we are dealing with systems that are all interlinked and interact with each other. I'm not going to get into a lecture on systems at this point, but there is a large body of evidence that is used to help us to see through these things and how they interconnect. Basically finding out who is in charge of each bit of the system, what it is that they're doing, what is their world vision. We use the term Weltanschauung, a German word, to understand how they see their bit of it, the environmental constraints, who owns it, who can make the final decision about continuing something or stopping it. So that was where we were coming from, that we needed to be seeing all of these different bits and how they related, and basically who was in charge.
Thank you. And you say basically who is in charge, and so was there some doubt in your mind as to who was in charge in September 2020?
Well, we do say that, at least in one of the reports, that obviously Baroness Harding was in charge ultimately, and there were a group of, I think, 15 people and the senior management who were looking at different bits. We were concerned about the lack of a public health input there and the ability to bring all of these things together. I think the concern that there was insufficient attention to within a complex system like that, one should be monitoring those groups that are not being tested, identifying the barriers they face and doing something about it.
Thank you.
We felt that there were a number of gaps there that had a proper systems approach being taken, then many of those problems, which we have heard in the impact statements, many of those problems would have been addressed.
Now I'm going to take you in a moment to the statement you referenced around the role and involvement of Dido Harding. But before I just leave the content of paragraph 14, there is the criticism contained within that statement to the United Kingdom system, NHS Test and Trace. And can I just clarify, do the criticisms that were pertaining at that time in September 2020 apply equally to the approach to test and trace adopted in Wales, Scotland and Northern Ireland?
I think it's fair to say that we did not give so much consideration because most of us did not have the detailed knowledge of to be able to distinguish what was going on there.
Thank you. Well, let's then move together to the document where we do see the reference to the role of Dido Harding. It's the Blueprint to Achieve an Excellent Find, Test, Trace, Isolate and Support System, INQ 45926. And if we ask for that to be displayed, please. So INQ, sorry, 145926. I apologise, I gave a rogue reference. Thank you.
Yep.
Perhaps if we just orientate ourselves, we can see that we are now in October the 16th, 2020, when this document was published. And if we turn over the page, please, to the blueprint to achieve an excellent find, test, trace, isolate and support system, why was it felt in October 2020 that there was a need to be setting out a blueprint from Independent Sage's perspective?
Well, because we felt that the system was not delivering what it should have done, because by this stage we had seen the experience of a number of other countries, South Korea most notably, but actually Germany, Belgium, Uruguay, various others that seemed to be doing this much better. And so we felt that, well, first of all, having a comprehensive system was important to arrest the spread of the infection, but also to allow people to live as normal lives as possible. It's both parts. And in our other papers, we've talked about the different roles that testing can do. And I know that Professor Buchan will also be talking about this later, because he and I co-authored one of the papers that looked at this. There are many purposes of testing, and it is about balancing. It is about trying to reduce as far as possible the spread of the infection, but also minimizing the adverse consequences. And we felt that it wasn't delivering that. We felt that we were getting the worst of both worlds.
Thank you. Now, we can see the summary of the blueprint that's set out there, which was Independent Sage were calling for the replacement of what's described as the failed, falsely named and private sector-run NHS test and trace, with a system for England which is rooted in the regions of England and in local areas. It must be integrated throughout with the National Health Service and provide for the needs of people in the communities in which they live. Is there anything further you wish to expand upon?
Yes.
Why that was the view of Independent Sage?
Yes, because we did not feel that it was actually delivering on the testing and tracing. I would maybe want to clarify the point about private sector involvement. We're not ideologically opposed to private sector involvement. The private sector is clearly hugely important in many areas, like the production of technology and of pharmaceuticals and so on. And many of us, myself included, have worked closely with many of the major pharmaceutical companies in the past, and therefore recognise that they have a role. But the difficulty is, and this partly stemmed from earlier work that we had done looking at the private finance initiative, and the challenge that came out of the papers, the work that I and colleagues had been involved in, yes, there's the expense, but the fundamental problem is that once a contract has been agreed, it is incredibly difficult to change. And we see that with the PFIs for the hospitals, where the models of care have been developing over the 25 years of the contracts, and you can't really change them. And that actually came out from one of the other documents that you supplied me with and asked me to comment on, a meeting between the Secretary of State for the Foreign Commonwealth Office and the Secretary of State for Health and the Chancellor of the Duchy of Lancaster, where a paper was produced which looked at experiences in other countries. And the comment from the Health Secretary was, yes, thank you, but of course we have already designed the test and trace system, and therefore we can't actually change it. I mean, obviously they could in due course, but we were concerned about the inflexibility, and particularly when we looked at some of the experiences where the Army had been delivering the mobile testing centres and had demonstrated a degree of flexibility. I think one of the papers that I referenced illustrates that they were able to, for example, the contract specified that the testing centre should be open during working hours, but it was in a place where many of the workers were on night shifts, and that could not be changed. Whereas when the military were doing it, they could change it. So I think that is the flexibility in these contractual arrangements, which actually other countries like South Korea seem to be able to overcome. There's a less adversarial system and a degree of flexibility that we seem to struggle with doing. So it's really the flexibility to adapt to changing circumstances.
Thank you. Can I just pause you there? You referenced in giving that answer one of the documents that's been provided, I think, as part of your evidence pack. And is the document you're identifying the minutes of the Foreign Secretary and First Secretary of State's meeting regarding international comparators of the 8th of May 2020? I'm not going to take you to it, but for completeness, my lady, that's INQ 88651. I just wanted to orientate the date of that meeting you're referring to. Can we then return to the blueprint, the SAGE blueprint, please? And I'm looking now at the third bullet point, please, we see there. It says this: in each top-tier local authority, the local director of public health should have the leadership role and convene the necessary management structure in conjunction with the local NHS and local authority. Why were you making such a call in October of 2020?
Well, I think this reflects a view that we had, many of us had, actually since the changes in 2012 when the reorganisation of the NHS took place and the role of the director of the public health, in our view, was somewhat diminished and obviously had suffered from loss of resources. But we still felt that these were the people who, I go back to my point that public health is the glue in the system. It is having the epidemiological knowledge, but if you look at, in our training, because we train many of these people who go on to these roles, they have training in economics and sociology and behavioural sciences and epidemiology and statistics. Now, obviously, if you have a complex statistical question, you will get a statistician to do it, but it is the ability to bring the things together that we feel that the director of a well-trained, highly motivated director of public health should be able to do, to understand that it's not just about the numbers. They can understand the graphs, they can understand the trends, but they also understand the social determinants of health, the inequalities, their causes, and so on, and can synthesize it. That's where we feel that they can make a contribution.
Thank you. Turning then to the next bullet point, it records laboratory capacity in particular is crucial to our ability to control the virus throughout the United Kingdom. Independent SAGE calls for the establishment of a national COVID testing consortium, including all current providers under the auspices, oversight and management of NHS. So just pausing there to understand the point that was being made. The inquiry is aware that at this point, the project of establishing lighthouse laboratories had commenced. Can you assist with what was being said there about what was required around laboratory capacity?
I think you will hear more from Sir Paul Nurse and Professor Alan McNally on this. However, reading what they have said, in fact, we do quote Paul Nurse in this in this report. There was a sense that there was capacity that could have been used and was not being used. There were problems with the flow of reagents. And he will say this much more eloquently and with much more detailed knowledge. And I think Professor Pillay will also talk about this later on in this module. But from what we were hearing, and of course Dean and Pillay, Professor Pillay was one of our members in Independent SAGE, then we felt that there was a need to bring everything together so that people could identify where the problems lay and what might be done about them. We felt that it was fragmented. And we felt that, I think you will hear more about what we felt at the time.
Thank you. And in fact, we don't need to turn to it at the moment, but just whilst we touch on that topic, you do detail within the witness statement the concerns regarding the outsourcing of the TTI programme, despite the availability of NHS public health, veterinary and academic laboratories. And you've already touched upon the concerns relating to Mensa, but also the underutilisation of existing capacity, smaller targeted testing facilities to go alongside the development of the larger lighthouse labs.
Yes, because the situation in different parts of the country will be different. The way in which you organise the testing will be different in London from the Outer Hebrides, for example. So I think you do need to have that degree of flexibility. And has been a concern that we've had about many of these centrally led initiatives. Of course, the science is the same everywhere. The principles are the same, but there should be sufficient flexibility, as there was in South Korea or in Germany with the decentralized structure, to adapt to what the situation that you're faced with is.
Thank you. Now, the next bullet point is the following: isolation will not work unless people are supported to enable them to isolate. Self-isolation should be replaced by supported isolation. with assistance if needed with accommodation, domestic assistance and financial support up to £800. And again, perhaps just to orientate at this time, particularly in England, there had been from the September the availability of the £500 under the Test and Trace Payment Support Scheme. Can you assist on why it was that Independent Sage was suggesting the £800?
Well, I think when we work out first of all, a lot of people were not able to get the £500. So that was a problem, and it was a complex system. And I think we've heard that there were differences in the ability of people to get it in different parts of the country. But we just felt that it was inadequate, actually, for the cost that people were bearing. Well, I can't say that we did anything particularly using primary data to come up with £800, but we certainly felt it should be more than £500. And we also were mindful in all of this that the amount of statutory sick pay in the UK is right at the bottom in Europe. In fact, in the table I have here, it's below Estonia and Slovakia and Bulgaria. When you look at the first week of sick leave. So we were being very miserly compared to other countries.
Thank you. Can we move then, please, to the next page of the blueprint? We can see that it details 8 months into the pandemic. It's clear that England's Find, Test, Trace, Isolate and Support programme is failing, leading the government to rely on a succession of restrictions on people mixing to control the pandemic. The result is that the United Kingdom has some of the greatest excess death rates and economic damage anywhere. In the second quarter of 2020, the UK's GDP fell by 20%, or around 143 billion, according to the OECD-1. South Korea, which rapidly suppressed the virus through a smart system of test, trace, isolate and support, experienced only a 3% drop in GDP, with only 2 short local lockdowns. And again, can I confirm, was that the universal view of Independent Sage at this point, that the system was failing?
Yes, I think it was, as far as I recall. I think so.
Now, I think this is the passage you've already highlighted. We can then see who is in charge, asked our Nobel laureate, Sir Paul Nurse, in several media interviews earlier this year. The answer for Find, Test, Trace, Isolate Support is Baroness Dido Harding and her 15 advisors, in what is now the most important boardroom in the United Kingdom. Thousands of lives, jobs, businesses and pensions, as well as the NHS, now depend upon their decisions. Yet the board has no director of public health, no data scientist, general practitioner or nurse, no social or behavioural scientist, community mobilisation expert, virologist, local politician or NHS logistician, We believe the government now needs a radical reform. And so can you just be clear about what was really being said at this time?
This was the point that we needed to have the testing and tracing system as part of a broader system, in which would encompass all of the things that we were saying and all of the elements that we had on our snakes and ladder graphic. We just felt that there was a very much a numerical focus on getting the number of tests up, the number of people contacted, but without really thinking through what it was trying to achieve. And in the previous paragraph, we'd basically alluded to the view that there are alternative ways of doing this.
Thank you. I'm going to, before leaving this document, take you over the page again, please, and just to ask for some clarification, please. On paragraph 3, we can see it's identified that the key local figure with a responsibility for population health is the local director of public health. Within each upper tier local authority in England, the appointed director of public health should be placed in charge of organising and managing the FTTIS programme. In Scotland and Wales, they cover manageable populations and work closely with the multidisciplinary outbreak management teams. Northern Ireland is handicapped by having, since 2009, only a single Director of Public Health for the whole province, and they should consider how public health expertise and the FTTIS resources can be deployed to ensure adequate connection with local communities and councils. The active involvement of key health professionals at a local level, including GPs, community pharmacists, health visitors, environmental health officers and school nurses, will be extremely important and should be part of ongoing communication networks, then ensure that everyone understands the vital role that they can play. Are you able to comment any further on how only having one Director of Public Health negatively affected Northern Ireland?
I think the problem there was that there had been a sustained disinvestment in public health. When I qualified from Belfast, I trained in internal medicine, then subsequently in public health, and I worked in public health at a time when there were 4 health boards in the province. And at that time, there was a substantial public health infrastructure which had been eroded quite markedly. I left in 1987. So I think that it wasn't just that there was only one Director of Public Health. It was the fact that this was symptomatic of a significant disinvestment. But again, it goes back to the need for local knowledge, because although it is only a small country, a small territory, there is quite a lot of diversity within it. In fact, we heard from one of the impact statements that in the rural areas of Fermanagh or Tyrone are very different from the built-up areas, the post-industrial parts of Belfast. So I think having that detailed local knowledge, and in particular, I think what is so important in all of these is that the Director of Public Health has the personal contacts and the trust and those relationships that allow you to work out where there are weaknesses, where maybe somebody is not up to it and they need to be supported or replaced or something like that. And it is quite difficult in a territory that is actually the size of some independent European, larger than a number of independent countries like Iceland or Malta, or even getting up to the population of Slovenia or Estonia.
Thank you. Now, again, just for matters of chronology, can I take you briefly into the statement on the Immensa laboratories, which was published on the 22nd of October. It's INQ 535915. Thank you. If we move over the page, please, we can see detailed there, and I'm not going to go into the detail, the concerns that Independent Sage had as to the move to the use of the private contractors. But then can we move over the page again, please, to paragraph 7. We can see a call again for the need to rapidly reassemble Public Health England, NHS and aligned university laboratory capacities and their clinical leaderships to drive future laboratory support of COVID response. This should be associated with the migration of outsourced contracts back to such a consortium wherever possible. Now, obviously, this is as the Lighthouse laboratories were established and being increased. And I don't want to display the map of when each was opened. Yeah. But again, can you provide any detail, or are you deferring to others to give the detail as to why, still in October 2020, there was this call to essentially do something different around laboratories for testing?
So, the first paragraph of the recommendations, we called for a rapid publication of the report of the UK HSA review process, which we now have, the final report of the serious untoward incident investigation. We were concerned about issues of governance here, of oversight of the contracts, and I have to say all of our concerns have been were in fact validated by that very detailed review by UK HSA. And we found that, for example, statements were made that a senior public health doctor said that the lab was accredited to all of the appropriate standards. A government spokesman said the lab was fully accredited by the UK's Independent Accreditation Service. And then the UK Accreditation Service said that it wasn't. Neither it nor the Italian labs that were part of the same company had ever been awarded UCAS accreditation. And what became clear was that what was being accepted in the due diligence for these contracts was a commitment to become accredited rather than actually be accredited. So there were lots and lots of concerns, and there are many more, of letters not going unanswered, no one quite clear who to talk to about the problems. And we just felt from what we had at that stage in the public domain that it really wasn't working and somebody needed to look at it again.
Thank you. And I think if we could just go back a page, please. We see at the bottom of page 2. Thank you. The reference there to, I think, the statement in the aftermath, Dr. Jenny Harries announced that the laboratory in question was fully accredited, and the rest of the detail just set out.
Yeah.
Thank you. Can we then move to just some general questions, please, around TTI mobilisation and infrastructure? And could we please display INQ 000535912, which is the independent SAGE position paper on supported isolation? Thank you. So we can see this document is March 2021. And can we move then, please, to page 4? And we can see under the paragraph, the UK experience with supported isolation, it's recorded that in March 2021, Independent SAGE expressed the view that the UK could have broken transmission chains if we'd mobilised local test and trace capacity during February and early March 2020 with proper incentives for isolating households and community facilities provided for less severe cases. And so can I ask, do you maintain the view expressed by Independent SAGE and consider that TTI could have been effectively mobilised in March of 2020, despite barriers including the lack of infrastructure and speed of the seeding infection?
I think that it could have been mobilised. I mean, obviously, whether we would have definitely been successful, that's a question that we can't answer. We don't have the counterfactual. But and it was, of course, complicated by the fact that there was so much seeding of cases across the United Kingdom coming in from holiday resorts and people coming back from holidays and so on, and obviously the football match in Liverpool and so on. So I think that I'm not sure I would say with absolute confidence that we would have done it, but I think that we would have had a much better chance of doing that. And particularly because whenever those local test and trace teams led by the very competent directors of public health in places like Leicester and Sandwell and Liverpool and so on, when they did get mobilised, they were able to add substantially to what was being done by the national test and trace system because they had the local knowledge. And of course, we also wouldn't have had to wait. The thing is that I think it's often underestimated just how difficult contact tracing is. People who contact trace for meningitis or for tuberculosis or sexually transmitted diseases are often soliciting from individuals the most intimate details of their life, who they did different things with, what they did with them, and so on and so forth. And that requires a degree of skill now. Obviously, there is a limited tracing capacity, but it would have been possible, in our view, to have redeployed people under their guidance and support, as happened, for example, in intensive care units. We didn't have enough intensive care nurses to manage all the ventilators, but one could manage less well-trained staff to look after 2 or 3 of them, and therefore essentially multiply your force. So I think that we could have done more. I can obviously not be certain that we would have been able to have stopped it. And I also have to recognise that, to go back to the point about complexity, where path dependency starting conditions are incredibly important. We were not in a good place, and my lady, your report from Module 1 makes this very clear, that we were not where we would have wanted to have been, whereas South Korea and Germany and other countries were in a much better place. So I think we could have done better, but I can't be confident that we could have stopped it.
Thank you. We will come on to look at international comparatives, particularly around contact tracing, when I move to another topic. But can I ask you just on another document that's been provided to you, please? Could we please display the Academy of Medical Science paper INQ 00475107, and this is an internal page 36 of that paper, which was from July of 2021, and I know you've had an opportunity to consider this document, and obviously this was also commenting on the Academy of Medical Science view as to failings in TTI. But having had a chance to consider this document, do you agree that the United Kingdom failed to prepare adequately for the predicted autumn second wave?
I do. I'm afraid. I don't think that the time was used in many ways, and not just in this. I think that one of the things that other countries did, I'm thinking of Germany and Belgium in particular, was to really prioritise ventilation, filtration, clean air quality. That's something that we really could have done to allow us to reopen particularly schools much earlier to make them safe. But I felt that there was a sense that almost this would be over by Christmas, and among many people, and we did not put in place all the things that needed to be there. Yeah, I agree with that.
But can I ask you, because I think this Academy of Medical Science paper identifies the failings that they've identified was failing to improve testing, tracing and isolation, despite the calls that have been made from bodies such as the Academy of Medical Science. So I know you went on to deal with, you accepted that around ventilation and air quality, but do you share views as to the role that TTI played in respect of the predicted second wave?
I do.
And that having been established, could you assist as to what steps should have been taken during this period, and particularly towards the second wave?
I think what was already happening in some of the local authorities that I've already mentioned, I think we should have been learning the lessons from them and finding out what worked. I mentioned Leicester in particular, Sandwell and some others, and looking at how we could have replicated that elsewhere, because they were working with the national test and trace system, but they were going beyond it. There were a lot of issues around data flows, and I think Professor Buchan will talk to you about the challenges that they faced with getting data in Liverpool. So those arrangements could have been resolved, I think, during that time. The communication networks, the communication pathways could certainly have been improved. So just generally making the system work better. I think at the same time we were finding that there were parts of the country where, not unsurprisingly, places where there were large numbers of families and homes in multiple occupancy, overcrowding, from ethnic minorities where there may have been issues with language and so on. I think more could have been done to understand the barriers that had to be overcome to put in place to make sure that the system was as responsive as it could be. Because in effect what was happening was that those communities where, by your inability to really drive down the infections, you have a locus from which the cases can then subsequently expand.
Thank you. That can be taken down, please. Can I then seek your views, please, on the topic of asymptomatic transmission, which you've touched upon throughout your statement in various places, but perhaps if we orientate ourselves, and it doesn't need to be displayed, if you want to go to your paragraph 23, where you've commented upon the acknowledged challenge posed by asymptomatic individuals who can unknowingly carry and spread the virus. This underscores the importance of widespread testing and effective tracing to identify and isolate these cases, even when symptoms are absent. You've also helpfully referenced in your statement studies you published in June of 2021 looking at lessons from countries that implemented find, test, trace, isolation and support. And I think those reviews also observed that rapid testing strategies, including point-of-care testing and serological assays, were implemented to confirm outbreaks and detect asymptomatic cases. And can I seek your view then on the position that at one point that there was no value in testing even when symptoms were absent.
I think it goes back to my point about finding as being a find, test, trace, and so on. I think what we learnt from a number of episodes early on, in fact, from February 2020, March 2020, that this was a infection that was spreading among people who were asymptomatic, and particularly a whole series of examples from choirs in the United States, in Seattle, in South Africa at a funeral, where people had done the backward contact tracing, in a case in a church in Korea, where 5,000 cases were linked to one church service. And that highlighted the importance of going out to find people, to recognize that the transmission was occurring before people developed symptoms, which is unlike with a number of other viruses. And it just adds to the difficulty that we face. Often, with others, people are spreading once they have actually become infected, and that's somewhat easier to deal with. But this was a virus that was already spreading in people who had not yet developed symptoms. So it called for doing something other than waiting for them to develop symptoms and then coming forward for a test. So I think asymptomatic testing was important.
Thank you. Can we then...
Can I just ask, when do you say February onwards that should have been...
Well, there were examples from other countries. It comes back to this point about learning lessons from elsewhere, which I don't think that we were terribly... we were doing terribly well. And there were a number of cases in Amsterdam, in Germany, in Seattle, where this was becoming clear. I think it was not appreciated whenever the virus just first emerged. The assumption was that people would get infected, they would start coughing, and they would spread it. But then we already had the signs from February, in fact, from some of from South Korea, but multiple cases that came out that really did, for many of us, did set the alarm bells ringing, my lady, but didn't seem to have set them ringing in all the right places. And I think, as you have heard it elsewhere, there has been a reluctance for a long time to accept the nature of the airborne transmission of this virus, even though the evidence was accumulating.
Thank you. And just on that timeline, could I take you, please, to INQ 475172, which is the press release that accompanied the further expansion of access to coronavirus testing on the 28th of April 2020. And if we just move to the next page, please, we can see that on the 28th of April 2020, the United Kingdom government announced that testing of all asymptomatic NHS and social care staff and care home residents was being rolled out, working with Public Health England, the Care Quality Commission and the Association of Directors of Adult Social Services, and that the government were piloting sending packages of satellite test kits directly to care homes across England to enable testing of residents. And can I ask you then, are you able to comment on the likely impact of the delay in ensuring regular asymptomatic testing for care home staff and residents from the 28th of April until mid-August 2020?
I think that is a question for the modelers, but I might make a broader point on this, if I may, which is that the continuing changing of the advice was confusing and undermined trust. And often, talking with my colleagues, we've developed a sense that with so many aspects of what people were being asked to do, it was to fit with the available resources, be it how much PPE was available, how many tests were available, and therefore the scientific rationale was retrofitted to that. Whereas I think if there had been a clearer explanation as soon as we had the evidence about the nature of transmission and what needed to be done, but also, and I accept that it's incredibly difficult politically to say, in ideal circumstances we would like to do this, but we cannot because there is a global shortage of lots of things, then I think that would help with trust. Now, it may then be more difficult for the politicians because they face more questions about what are you doing to fix this and so on. But the way in which many of these things are presented, it is as if, well, we're told that the policies will change without any clear explanation for why. And it's difficult to look at this and say that the nature of the virus has changed, the nature of the science has changed, particularly with a government that is claiming to have been led by the science. This gives the impression of being led by the resource constraints, which is perfectly acceptable and understandable. But it would help with, I think, preserving the trust, which is so important in all of this, and in eliminating and reducing the confusion.
Thank you. Now, I think your answers just cover this. Obviously, the delayed implementation of asymptomatic testing for healthcare workers is a particular concern of COVID Family for Justice Cymru. Is there any other clarification you'd wish to give about the introduction of testing in asymptomatic testing as it applies to Wales?
I can't say specifically with regard to Wales, but I think generally there has been so much written about the circumstances in which, I mean, by people like my colleague Rachel Clark in her book Breathtaking, or Dom Pimenta in his book about trying to procure PPE. I think we have... There is definitely a sense that people on the front line were not being listened to, and their concerns were not being heard, and many of the decisions that were being made did not resonate with the reality as they saw it, particularly as their colleagues were becoming ill and tragically, in too many cases, dying.
Thank you. Can we look together then, please, at your paragraph 62, which is INQ 475066 at page 23, paragraph 62, still on the topic of asymptomatic testing, and perhaps almost on the theme that her ladyship has heard from Hazel Gray today around the experience of her father contracting COVID in December 2020, that she believes was brought into the home by care workers who were not being tested. You say this: regular asymptomatic testing for care home staff and residents began in July 2020, but access to tests remained a challenge for many, with care home testing being unreliable until mid-August. Laboratories struggled to report results promptly, with less than 40% of tests returned the next day, leading to significant delays. This underreporting suggested that the actual number of new cases was much higher than reported, with estimates indicating around 9,600 new cases daily. And so is there anything further you want to say around the sort of the delay still even after the announcement in April 2020 for actually going back to your boots on the ground position, for this to be happening in practice on the ground in care homes and other institutions up and down the country?
We wrote a paper at one point with a colleague at LS, London School of Economics, who is an expert on the social care system. And we asked, did the government really throw a protective ring around the care home sector? And we concluded that it didn't. There was definitely a sense, and that's come out from my colleagues who are modellers, I've already mentioned, of a lack of understanding of the nature of the workforce in the care home sector. The irregular employment, the gig economy, the people working in multiple places. And I think that this really would have benefited in our impression. And again, I stress that I was not in the room where these decisions were being made, so I cannot know what, and this is an issue for the inquiry, obviously, what was being discussed and what was being considered, but it did seem strange to us that this was not a priority with a lot of vulnerable elderly people, but also the way in which care homes are a classic example of an incubator of infection. Now, in my previous work, we had looked at other incubators of infection, in particular mines in Africa, where migrant workers come together and infection spreads. The cruise ships were another example from early in the pandemic. Prisons in the former Soviet Union, where I've worked a lot. So care homes were one of these places where people mix together in close proximity, and you can actually spread the infection very effectively because they're not isolated. People are moving in and out. The staff are moving in and out. And therefore, this seemed to us that it should have been a priority, because we should have recognised that these were the incubators, the institutional incubators that we were very familiar with from the literature on, as I say, from mines, from prisons and from elsewhere.
Thank you. Professor McKee, sorry, that can be taken down. Thank you. Professor McKee, I now wish to seek the evidence you can give to assist the inquiry with the additional views informed by your knowledge of international experience. And to do so, can we use an article you co-authored? It's INQ 535928. And we can see it was titled Fixing England's COVID-19 Response Learning from International Experience. And if we look over the page, please, page 2, you there set out a wide range of recommendations in respect of testing, tracing and isolation. And so can I pick out some of those topics and seek your assistance, please? We can see under recommendation 2 for testing, validate and implement pooled reverse transcription polymerase chain reaction for surveillance testing and asymptomatic testing of healthcare workers, care homes and hospital pre-admissions, and initiate environmental surveillance by testing wastewater as an early warning system for outbreaks. Can I ask you, first of all, just to give clarification about what pooled testing is?
Sure. So essentially, if you have, you've got one test, or as you say, you've only got 2 tests left. What you can, or a small number of tests, you can take all of the samples, combine them together, and if you test them and find there is no evidence of infection, you can say maybe there were 10 people samples pooled, you can say that's fine, they're all negative, and then you can move on and look at the next 10. And whenever you do get one that comes up as positive, then you use your tests to look individually at the samples that went into that. So it's a way of economizing on the testing. And in fact, laboratories in the NHS were doing this anyway. Some of them were doing this, but we felt that this was something that had proven to be helpful elsewhere and should be looked at and perhaps used to a greater degree. I'm not entirely sure just how much was taking place. Some was in the United Kingdom, but I gather not everywhere. And then the second issue was about testing wastewater. We know that that is a very effective way of monitoring the level of lots of things, in fact, in the population, from infections to cocaine. And most European countries have continued to monitor COVID in the SARS-CoV-2 in their wastewater. England hasn't, but other countries have. And again, it's another signal. And it comes back to my point that as in any form of intelligence gathering, you want as much information from as many sources as possible to synthesize. And this is just more information that helps you to find things.
Thank you. Can we just turn to the next page, please? And it's the first column. If we just scroll down a little bit, it's the paragraph that starts with one way. If that could be expanded, please. You detail within this article that one way to significantly increase capacity in a relatively short space of time is pooled testing. And you go on to identify the pooled testing that had been used successfully in a number of countries, including China, the United States of America, Germany, Portugal, New Zealand, Rwanda, Uruguay, Israel, and Vietnam. And can I ask you, should decision makers in the United Kingdom have been aware of the utility of pooled testing and implemented it effectively before autumn 2020, while incidence was low, in order to increase capacity?
Well, first of all, the point is that you can only do it when the incidence is low. Once it gets above about 10%, then it's not particularly effective because you're very likely to get positive samples in all of your pool tests, so it only works at a certain time. And clearly there were many people in laboratories that were very familiar with this and were doing it anyway. I'm just not sure how well that was appreciated at a more senior level, but it goes back to my point. I mean, I wasn't in the rooms where these discussions were taking place. It didn't seem that these messages were being picked up, and I think you will be talking to Professor McNally later on in the week. I think that would be a very good question because he will know much better than I do, or Professor Pillay.
Thank you. Would it be fair to say, as you weren't in the room, you can't really say what decision makers were having regard to, but have you seen any evidence of whether the international experience and expertise in respect of pooled testing was being considered?
That I can't say.
Thank you. Can we then just a little further down in the same paragraph, you recommend validation and implementation of pooled testing for surveillance testing and asymptomatic testing of healthcare workers, care homes and hospital pre-admissions. Do you know whether that was ever implemented?
I don't know. I don't know whether it was ever implemented. But these are the sort of areas where it is most useful, because you're expecting that your the numbers of infections within your pooled samples will be low. So therefore, this is not going to work where you're testing symptomatic people.
Thank you. Can I then go back a page again to your table of recommendations and ask some questions about contact tracing and also the importance of international experience? We can see that you recommended, in respect of tracing, to invest in workforce and technology in existing regional public health teams while providing further training to existing Serco and CITEL tracers and ensuring they follow up to check if people are isolating properly and need any support. And I think the inquiry aware that the contact tracing centres, the large volume that have been set up, were through call centres that Serco and CITEL were using. And so what was the issue around Serco and CITEL that you're flagging linked to contact tracing?
Well, it goes back to my point about contact tracing being a very skilled task. And it was not clear to us, and in fact it was clear that there were problems from the accounts that we were hearing, that having a very formulaic approach to going through it like with a script was not really working terribly well. And you do need that ability to be able to pick up nuances and so on. So I think it was generally an idea that it would have been better to have gone with the public health teams rather than bring in call centre staff who maybe 5 or 6 weeks earlier had been chasing up debts or looking for insurance claims or telemarketing or something like that. We felt that this was a more skilled role than was appreciated.
Thank you. And I don't need you to turn it up, but with you referencing that issue, you do say in your paragraph 73B of the statement, contact tracing is essential for identifying individuals who may have been exposed to the infectious agent. This requires a well-trained workforce. This is definitely not a role for individuals with minimal training, working off a checklist or flow diagram.
Yeah.
Okay, contact tracing is a highly skilled occupation, often involving asking questions about intimate personal details. They must be skilled in communication, cultural sensitivity and data privacy to ensure trust and compliance.
And I think this is borne out by the experience of those local authorities, or the local public health teams that did take this on, in that they significantly increased the number of people who were being contacted.
Thank you. And can I ask you then, with the issue of need for trust, are you able to comment at all as to whether the contact tracing and that centralised approach would have impacted upon the necessary trust that would be required amongst ethnic minority communities?
This is a really difficult one. We've recently been in the European Observatory doing a lot of work on trust. We had an interministerial conference in Estonia at the end of 2023, and we've recently published a book on it. And here I might just quote an old Dutch saying, which is that trust arrives on a tortoise but leaves on a horse. In other words, it takes a very long time to build up, and once it has, you can lose it so easily. And in fact, we saw that during the pandemic. There's a published paper which looks at the impact of Mr. Cummings' move to Durham and on levels of trust in England and in Scotland, where they were monitoring them separately. It was different. So these are communities that in many, and it will vary because there are a huge number of different ethnicities that will have had different sets of relationships with authorities and in different parts of the country. But in many cases, they have had good reasons to distrust authority. And I think it is really important to look at what the reasons are for the distrust and how they can be allayed. And this is something that we know so much about already from vaccine hesitancy. Because if we look at the global campaign against polio, and again, it's something that I and others have worked on, looking at the way in which religious concepts are brought to bear to undermine belief in vaccine safety, we should know these things. We should be able to anticipate that they need to be addressed.
Thank you. Can we then look together briefly, please, at the topic of backward contact tracing? And we can see that you identified in the recommendations at 3, increased resources to enable a greater focus on identifying clusters using retrospective tracing for more effective control. Would backward tracing be essentially retrospective tracing?
Yes, it is. And we recognise that whenever you're in the midst of the pandemic and the cases are exceptionally high and your resources are constrained, that you can't do everything, and you particularly can't do this. But we felt that this had proven to be particularly effective in countries like South Korea, where they had been able to maintain a high level of normality in day-to-day life by focusing on going back to identify the clusters and then identifying people who were infected that way. So we felt that it should have been given more consideration than it was. But we recognise that there are constraints in all of these things.
Thank you. Now, we can see, if we move to page 4 of the same document, please, around tracing in the... Thank you. Thank you. Page 4, thank you. So the first column is still the tracing aspect, and we'll look together in a moment about the observations you make about successful backward tracing in Japan, South Korea and Uruguay. But the inquiries received in earlier modules, the report of Professor Heyman, and in his report early in the COVID pandemic, he identified that studies in Japan traced contacts of persons with COVID-19 forward for isolation and monitoring and backward to the source of infection. They then shut down those areas where transmission was shown to be occurring until preventative measures could be reinforced at those sites. And Professor Heyman commented that such precision and short-term lockdowns demonstrated that, unlike influenza, initial COVID-19 outbreaks could be contained and transmission interrupted, and also noted that the same was true in Singapore and South Korea. And I think you've been provided with a copy of that extract of the report. We can see that in your article, you and your co-authors were making a similar observation about the successful use of backward tracing in Japan, South Korea and Uruguay. And are you able to assist them? Was there any reason why effective backward tracing could not have been implemented from the outset in the United Kingdom?
I think in fairness, there was, my sense is that there was a recognition that public health in the United Kingdom generally had been underinvested in. And it was much weaker than it had been in the past, especially, I mean, if I look back to when I was training in public health in the 1980s and early 1990s. And so I do, and again, other people can answer this better than I can. My sense is that there were low expectations of what public health could have delivered because there was a feeling that it was not in a good place. And I suspect that may have been something to do with it, and the fact that the public... And I was speaking at a conference in Birmingham last week, actually, to a large number of people in health protection, and I was making some of these similar points, and there was very widespread agreement that they had not been... people had not been brought in, they had not been spoken to, they had not been involved to anything like the extent that they could have been. And I think that there was a feeling just that, you know, are they really, is there enough in place? Are the structures there? And I feel there was a sort of degree of defeatism, my sense.
Thank you. I'm going to stay with this document, but I'm just going to reference what you say in your witness statement at your paragraph 45. And it is on the theme that you've just identified about the impact to public health of cuts. You say contact tracing requires a well-resourced public health infrastructure and a trained workforce. Despite the use of digital technologies, manual contact tracing remained essential. Countries with decentralised systems and a strong connection to local services were more successful in detecting clusters and complex outbreaks early. And you then gave examples of South Korea, Taiwan, Germany, New Zealand, Denmark and Vietnam as to their approaches to contact tracing. We have the full detail in the witness statement, but is there anything else you'd wish to draw out about the learning from those countries?
The issue of the extent to which the UK learnt from other countries has been addressed at length by many other people, including a report of the joint report of the Health and Social Care and Science and Technology Committees in Parliament. And in particular, Jeremy Hunt and others have commented on this. Jeremy Farrer has also commented on it in his book, the former director of the Wellcome Trust and now chief scientist at WHO. And there is, I think, widespread agreement that there was insufficient learning from what was happening in other countries. And when it happened rather late. I mean, I've gone through some of the early statements, and we did have a memorandum with understanding with the European Centre for Disease Control, but it was only signed on the 1st of December 2021.
Thank you.
So we didn't have. There was, I think, a lack of. I think we'd lost a number of the informal contacts we'd had before, and yeah, I think it was a problem.
Thank you. And we are going to hear evidence from Lord Bethell, who had a key role in respect of TTI. And we have a statement he's provided which says, and we'll explore it with Lord Bethell, I don't believe we did enough to learn from countries like Taiwan, South Korea and New Zealand on their use of contact tracing technology. I pushed hard on the Taiwanese example in particular, which he believed could have been a realistic example to follow. And I'm disappointed that this was not pursued with greater enthusiasm. And so can I ask you, particularly on the Taiwanese example and contact tracing technology, can you give us any further detail about what is so unique about Taiwanese contact tracing technology?
Well, I don't think that it was unique. It was just that it was well developed because, of course, they, like a number of countries in East Asia, had the experience of the threat of SARS in 2003. So I think they were just generally prepared, and they did have a strong infrastructure in place. Now, it became more problematic later. I should say that I visit Taiwan every year and have done for many years, and so I work closely with Taiwanese colleagues. So from my point of view, it was very easy to have those conversations to see what was going on. I'm not sure what other connections there were between the UK and Taiwan. You will obviously be aware of the geopolitical situation there. But it did seem that they were the first to become aware of the outbreak in Wuhan after China. They had been gathering chatter on social media sites. They had acted extremely quickly. And they've had a long-standing record as having very strong public health infrastructure.
Thank you. Now, just looking back at the article, please, and we can see one of the areas identified was the delivery of contact tracing with the Massachusetts example. And so can I ask, in terms of, according to your research, backward contact tracing combined with standard contact tracing had the potential to double the effectiveness of the NHS test and trace system. And could I ask, do you have your views as to whether this was a system that could have been implemented relatively quickly using the Massachusetts example that you've cited?
The thing is that no model from anywhere else can be taken wholesale and just put down and you expect it to work, because again, going back to my point about the need for a complex systems approach, you need to know what's already in place, you need to know what the connections are and so on. But I think that all of these examples could have informed what we did and should have, I think, raised the question of whether we had whether our expectations were high enough, whether our ambition was high enough. And I have to say, I felt sometimes there was a sense that our ambition was not as high as it might be, which was, of course, complicated by the fact that some people were arguing at the time for herd immunity. So that was another factor that politicians were hearing from one side, that actually maybe you shouldn't be doing all of this and it's a matter of suppressing the curve and just waiting for it all to be over.
Thank you. Now, again, in the highlighted passage in about the middle of the page, we see reference to Operation Moonshot. It's described as much less costly than Operation Moonshot, and the efforts have been made to contact trace.
Yes.
Can we just first of all identify what Operation Moonshot was on the chronology? We displayed as part of the opening yesterday when essentially the system moved from the thought process of Operation Moonshot to then the programme of community testing. But perhaps can I just identify with you and that is it correct, and is it your understanding that in July 2020 consideration was given within government of whether rapid testing delivered on an all-citizen basis could be viable, and that's what was referred to as Operation Moonshot?
You'll have to forgive me if I don't have the exact chronology in my head for all of these things. So much was happening, but it was certainly being discussed at around that time. And it was an idea. I think it built on this concept of mission-oriented work, where you have a target to achieve, and therefore you throw everything at it. And the example is the Apollo moonshot, of course. And it was an initiative that when we saw the presentation on it, we had some considerable concerns, partly for for a number of reasons, but one of which was that it seemed to be replicating what we felt was a not optimally functioning centralized system being dictated from above and being imposed on very heterogeneous communities in the UK, and very different from what was being talked about in Liverpool, for example, which had some superficial similarities. Again, Professor Buchan will describe this, but was deeply embedded in the community.
Thank you. So summarising Operation Moonshot as a mass testing of the whole population at least twice over a 1 to 2 week period, accompanied by isolation of everyone who tested positive, which was a thought process of Mr. Johnston to eradicate the virus. You authored an article which you characterised as "Why did you as Boris Johnson's moonshot becoming lost in space?" Why did you so characterise it?
Well, in fact, when I looked at the slides, the point about a systems analysis is all the different bits need to connect up, and there is one slide. I'm not sure if I can find I have the slides here somewhere in this rather large pile of documentation, of a large number of circles floating around, a bit like celestial bodies in orbit, but with no real connection. So I think I was motivated by that particular slide. There was a sense that it really did not address the issue of needing to be embedded in the local reality. And then there were there were a lot of conflicts in it. There were, for example, in one slide, there was a very detailed outline of how this would work on an hour-by-hour basis on a particular, on days. Such and such a committee would meet at 9:30, another one at 11:30. And then there were other bits which were somewhat vague, like set up a laboratory, procure the technology, without any further detail. So we found it difficult. And the other thing, of course, was that it was influenced by what had been tried in Slovakia. And I was concerned that if again, the idea of taking models from elsewhere and just adopting them wholesale, it was important to find out what had happened in Slovakia. Unfortunately, I obviously got colleagues in Slovakia, and we wrote a piece for the British Medical Journal with my colleague, Professor Najeva from Kozice in Slovakia, which looked at what was going on there, why it was different. It was different because they had a very accurate population register. They had brought in not only their own armed forces, but armed forces from neighbouring countries. And they had a very punitive approach to people who were not being tested. So we did not think that this could easily be extrapolated, although, the Slovakian model as imposed in a smaller country, yes, it did have some benefits, but it didn't eliminate it.
Thank you.
So we could spot a lot of problems.
Thank you. And then finally, using this article on international comparators, can we go back to the table on page 1, please, just to briefly ask for any additional views on isolation. We could see that the recommendations to improve isolation touch upon a number you've already given evidence about during our time together. You were recommending expanding the criteria for pay cover by statutory sick pay, identifying employers who do not allow staff to self-isolate, to issue regular support information to those self-isolating, and following SAGE advice to allow swab isolating contacts. And so can I ask you, again, you detail in the article itself examples, international examples, but can I ask you, is the area of isolation and support one of the clearest examples of the amplification of inequalities by the COVID response in the UK?
I think our failure to support people who were isolating, I think, has been one of the major problems to suppressing this infection, because when we look at the parts of the country, particularly in the northeast and the northwest, in some of the in the urban areas, these are places we know that people are living very precarious existences. We've got lots of other evidence on that. And we had survey data. We had, again, Professor Buchan will be able to tell you about the very granular data they had from Liverpool. I think that was the work they did was amazing and a very valuable source that we could have learned much more from. So yes, I think that failure, the fact that there were so many people who were missing out on statutory sick pay because of our employment model, it was not very generous. And then, as we heard in the impact statement from Northern Ireland earlier today, or the witness from Northern Ireland earlier today, who described how care workers would come having not been tested because they were discouraged from being tested, because if they took time off, there would be nobody to do the job. So there was clearly an issue there. There were clearly issues there. So it resonated very much with that. We felt isolation. There's no point in testing somebody if they don't isolate.
Thank you. That can be taken down, please. Can I then ask you just briefly, we've already identified the payment support scheme, obviously the call early on for that a figure to be £800. But are you able to comment at all as to how enforcement of isolation, and we know in the United Kingdom and in Wales, if the requirement to isolate was enforceable with sanction, in Northern Ireland and Scotland it was strong advice rather than isolation with enforcement. Are you able to comment at all on the impact of enforcement policies and alongside isolation?
So in an ideal world, you would not have to enforce it, because people would have enough trust and they would have the opportunities, they would be able to be supported in isolation, that enforcement would be a very, very rare event. Ultimately, that is a political decision for politicians who will understand the limits of what they can do, and that may be rooted in history, it may be rooted in the nature of the relationship between the individual and the state. And if I was to look at Northern Ireland, I could think of many reasons why they might take a different approach in terms of the legal enforceability. So I think that they will have, but I think in circumstances like this, it is easy for us to say, well, politicians have to take into account other considerations. I do feel that whenever the scientific evidence is one of those considerations, then the other considerations should be equally made explicit, and they may be justifiable because of the history and the relations between different communities.
Thank you. Can I, two final topics. We've already touched upon the issue of the importance of equity and having regard to the impact on disadvantaged groups. But can I ask you, to what extent were the issues we've looked at together of the TTI system foreseeable as to the impact they would have, particularly on the ethnic minority communities?
I think they should have been foreseeable. I mean, it's difficult to see why they wouldn't be. The difficulty is that when you look at the very broad, some people say there are 300 different languages spoken at home in London. There are going to be some ethnic groups that actually have, and we know, have better health than if I use the word, I mean, the population that with its origins in the UK, and some that have much worse. And even within the Indian subcontinent, the Bangladeshi population often does significantly worse than the Indian or the Pakistani. And within all of those groups, there are differences because you have to factor in religion and caste and all sorts of other things. But even if we didn't necessarily, and that's where the local knowledge comes in, because in somewhere like Leicester, for example, they will be aware of, which is the Gujarati community or which is the community from, I don't know, West Bengal or somewhere like that. They will be different, but they will understand that in a way that somebody like me cannot, sitting in London, cannot possibly do. But we definitely should have been aware that those groups and traveller communities, Roma, I know that in the Northern Ireland, in Sir Michael McBride's statement, he talks about reaching out to the Roma community, but we should have been aware that all of these communities could have particular issues that needed to be taken into consideration.
Thank you. And finally, for my purposes, please, Professor McKee, you comment upon recommendations, which we've really touched upon around test, trace and isolate. We looked at them topic by topic. But can I ask you, do you have any views on whether there's now a lack of any meaningful legacy or strategy for the next pandemic threat?
Oh, dear. Yes. Yeah. I mean, we talked about wastewater testing a little while back. Most other European countries have continued to do that. We're not doing it. I really am concerned that many of the weaknesses that we had going into the pandemic, we still have, because many of the systems and structures have continued. Things have been dismantled. And the other issue is we're just about to have a major reorganisation. Well, we're having the abolition of NHS England in England. And that is going to lead to a loss of institutional memory. I think we need to remember that one of the problems we had was that exercises like Exercise Alice and Cygnus and others that had been done had been put on a shelf and people had often forgotten about them. The Phillips report on BSE, I think, should have been a Bible for anybody looking at a major crisis. And yet, it was all of those lessons were forgotten about, and I think that's deeply worrying. The loss of institutional memory, but also we still haven't addressed the strength of public health in this country. I think we still have many problems there.
Thank you. Professor McKee, we need to break. There's more questions after the break from...
No, we're going to carry on.
Thank you.
Thank you.
Milady, I'm not going to deal with Professor McKee, but we have helpfully been provided with the WHO pandemic treaty that's in place, and certainly it's something that can be brought to your attention as to a current change that's occurring. But I'll now sit down and hand over to those that have been given permission. I think, first of all, there's
Mr. Jacobs.
Thank you.
Mr. Jacobs, thank you.
Professor, just one question on behalf of the Trades Union Congress. I want to pick up this issue of financial and practical support for self-isolation, but also the issue just touched on of having a meaningful legacy and strategy for the next pandemic threat. How, in your view, should this issue of support for self-isolation be addressed in advanced planning for the next pandemic?
I think we need to have a serious information gathering exercise to understand what it is that prevents or makes it more difficult for people to isolate. And it's not just money. It's the availability of, in a number of East Asian countries, there were systems for delivering food to people, for example. That might be important. Delivering medicines to people. We will have, obviously, things have moved on because we have now found new ways of working digitally, communicating. But I think that there is a real problem. We mentioned at the very beginning, the Pan-European Commission on Health and Sustainable Development, where I was the rapporteur. We identified a major problem being digital inequality in digital access, which is a problem that for many of us, we're permanently connected to our smartphones. But for a lot of vulnerable groups, they're not. And it may not be that they don't have a smartphone. It may be, and Professor Buchan will talk eloquently about this because he did some really good work in Liverpool, that they don't actually have the airtime They don't have the data. That is linked to, well, all sorts of things. So I think we need to have a much more nuanced understanding of what people need. But it comes back to my point. We need to talk to people and understand, see the world through their eyes and not through our eyes, because people like me are not typical.
Professor, thank you.
Thank you, Mr. Jacobs. Mr. Wilcock. Well, it's not Mr. Wilcock. I'm so sorry.
Ms. McDermott. Unfortunately, Mr. Wilcock's indisposed today. Professor McKee, the questions I want to put to you today have been covered for the most part, but can I just ask you to clarify some aspects arising from your evidence? And I'm just going to reflect on what we've heard in Module 1, and I know from your evidence you've reviewed and rehearsed some of those expert reports. But in Module 1, we looked at and heard from Professor Whitworth and Dr. Hammer, who recommended that consideration should be given to learning from the experiences in China and neighbouring Asian countries. Now, of course, that's a critical perspective, emphasising the importance of learning from international responses that has been consistently echoed in your evidence today, and obviously in the various articles and reports you contributed and had written. But the experiences identified by Professor Whitworth and Dr. Hammer included, in particular, ensuring that hospitals and care homes were adequately resourced to cope with an influx of infected and infectious patients. Can I just confirm with you, do you say that there was a failure to adopt those type of measures in the UK?
So I think what happened in East Asia was that after SARS, they had constructed their facilities in ways that they could keep so-called dirty, unquote, and clean cases separate, and much more work on infection control and ventilation and things like that. We had not. And I think it is well known that our hospital facilities are, I should just preface this by saying that I've written or edited quite a few books on hospital design, and compared to the innovations and imagination you see in other European countries, the particular model that we have adopted has tended to go for the most basic construction rather than looking at the more imaginative ways in which you can do things. So I think for care home, well, that's more for hospitals, but I think that I don't believe that we had really factored those issues in so much.
And the other aspect of the lessons that you refer to from learning from others, would you say that that's primarily because of the investment or lack thereof in public health that you've again rehearsed today?
Well, if we're looking at the UK as a whole, first of all, many in the scientific community have excellent contacts and on a scientific basis. So that happens all the time. And most research is now international. But I think, I have to be careful what I say here, but certainly since 2016, our informal contacts have become, in fact, I know because I see it almost from the other side, from the European side, much, much less good than they were before. And I think a lot of that is to do with so many of these channels being informal. And like with the paper that we did on Slovakia, my ability to call up a friend who is a professor in Slovakia, and we know each other well, we have mutual trust, to find out what's going on. There were a number of other times whenever something was happening in another European country and I could just call a colleague who would know. And I think that we have lost a lot of that. And but also I think that there has been a long-standing tradition that we tend not to look at what happens in other countries, and this has been noted in books on lesson learning and public policy, contrasting the situation here with, the classic one is Japan under the Meiji Restoration, where they were looking at ideas everywhere else. But there is a literature on this, a literature on the UK's willingness to take ideas from elsewhere.
I suppose that may well answer my final part of that question, and whether the failure to take the measures and look at the measures taken by other countries accounts for the stark divergence in the outcomes between the UK and particularly the Eastern Asian countries.
I think it contributes a large amount to it. It is complicated. I mean, even the measurement of outcome, and you need to separate pre-vaccine and post-vaccine and so on. But, we did not do well. And I think we should have been learning. But I'm not the first one to make this point. As I've said, it's been made in parliamentary committees. It's been made by people like Sir Jeremy Farrar and others repeatedly, and Richard Horton and so on. So I think, yes, I think there's a widespread agreement that we could have learned more. And, there were contacts, but I don't think they were anything like as good. And they are the informal contacts. It's the fact that you're talking to your colleagues in other countries, and you have been talking to them for 20 years.
I'm very grateful for that. I'm going to move on to talk about Northern Ireland specifically. And looking at the independent SAGE report of the 12th of May 2020, and for the record, that's INQ 000249693. I'm not going to bring it up on screen, but at paragraph 9, I'm going to quote that it states that managing the risk of importing cases from other countries without consequent high risk of transmission is vital. This should be introduced as soon as possible, treating Great Britain and the island of Ireland as distinct health territories. For the most part, Northern Ireland government tethered itself to the decisions of Westminster, and the Northern Ireland Chief Medical Officer, Professor McBride, accepted that Northern Ireland, prior to the 12th of March, there was a relatively small number of confirmed cases, and therefore contact tracing had the potential to have a significant impact in the course of the pandemic and delaying community transmission. Are you able to comment on whether the Northern Ireland administration did enough to engage fully with the introduction of independent SAGE's strongly recommended approach of case finding, testing, tracing and isolating?
Certainly we had conversations with the Health Committee of the Assembly, but not with the Northern Ireland government. And I listened carefully to counsel for the Department of Health in Northern Ireland yesterday on the rationale for stopping testing. The Republic of Ireland continued contact tracing throughout. And obviously it was a decision to be made in Stormont, taking account of the number of cases and the testing capacity. But that doesn't really explain why, given all of those that could lead to a decision at some point, that you might have to abandon testing and tracing, why it was the same at the same time as in the rest of the United Kingdom, if it is not simply that they were adopting what had been decided at COBRA. I think that is a question that needs to be asked of those who were in the room where the decision was made. But it does seem somewhat difficult to understand why the decision was made at exactly the same time whenever the epidemiology was so different.
Where there was capacity?
Yeah, so again, I don't have, and again, I tried in preparation for this, I was trying to go back to the data, and actually it is very difficult to get the historical data from the Northern Ireland dashboard, I've resorted to asking ChatGPT for the number of cases, and I'm not sure that the numbers are entirely plausible, so I hesitate to quote them. But again, it would be nice if that was a little bit more user-friendly. But that was a problem throughout the pandemic because, as you might know, I did quite a lot of media appearances in Ireland, North and South.
You did. Thank you, Professor McKee. My final question. In the second of two papers produced as a result of the COVID-19 Health System Response Monitor, HSRM, you summarise at paragraph 48, while testing was a critical component of the public health response, it needed to be part of a comprehensive strategy that included contact tracing and support for isolation. This holistic approach was necessary to manage and prevent the spread of COVID-19 effectively. My question is, to what extent did the Northern Ireland response achieve those aims?
Well, the Northern Ireland stopped doing stopped in early March doing many of those things, and the rationale was that other things were being put in. But we do know from other modellers and others, and I think that it might be the Royal Society or the Academy of Medical Sciences report, that adding a well-functioning test and trace system on top of all the other measures adds another 15 or 20% to the effectiveness. So I think it could have done more.
I'm very grateful. Thank you, my lady.
Thank you, Ms McDermott. Thank you very much indeed, Professor. That completes the questions that we have for you. Thank you for your help.
Thank you.
Very well, I shall return at 2 o'clock.
Thank you.